we went with the transfer to the elbow and fix it in the elbow. What is interesting, and very, very important, that proximal non-transferred part still controls the shoulder, the internal rotation of the shoulder. So we made also the anatomy of the pectoralis major, and you can see that there are the 5 separable parts. Pars clavicularis, mandibuloris, and then the sternocostalis, costalis, and abdominalis. And we use these 3 distal parts for transfer. We divide the muscle here, and after that we use this part of muscle. This is described here. Again, the 3 parts. And what is very important, that these 3 parts are supplied from 2 vessels, for 2 arteries, and 3 motor nerves. So it is important because if we destroy during the surgery one of the vessels, it could be possible. We have another one supplying this transferred muscle. Here you can see the surgical procedure. This is the muscle, this is the transferred part of the muscle, and this is the tendon of the flexor carpi ulnaris. We use it from distally, then we connect this tendon to the transferred muscle. Here will be the neurovascular bundle for this transferred part. Why we use this tendon from flexor carpi ulnaris or extensor carpi ulnaris? Because the original tendon of the biceps muscle is very, very weak, and it is not enough for the moving of the elbow. So I can show you one example. It was the girl 5 years with tremelic form. He had only the passive flexion on the right side. You can see she has the problem to go to the mouth with the hand. And 4 years after the surgery, you can see the extension is good for the hygienic necessities. And now you will see the active flexion of the elbow. Even in this, she is able to move with some items to the mouth. Okay, so we evaluate the patient subjectively, objectively. We made also the EMG activity of transferred muscle, and we made also the histology. You can see again some of the patient, and what is also important, this method doesn't involve or destroy the natural involvement of the breast in the women. It is very, very important for us. And we have the significant improvement in 6 patients, partial improvement in 4, but minimal in 3. And objectively, you can see also the range of movement was mostly very good in 5 patients, till 85 degrees of flexion in 2 patients, but unsatisfactory it was in 3 patients. You can see on this picture how this is an original picture in age of 5, and then in age of 16 and a half, very good formed new biceps muscle from this pectoralis major muscle. So when we go to the discussion and the literature, former literature reports reported only unilateral transfers with relative also good results, but we use the bilateral transfer. We published it in our journal, but also in the JPOA in 2012. And we can say that it's possible to make it bilaterally, and 14 and 15 years after surgery, the patients are skeletally mature. So we hope that it will be no further deterioration of range of movement, particularly the extension deficit. But because after the surgery after the surgery, couple of years, it could be the flexion contracture. So it is necessary to make the physiotherapy, but the normal evolution after then of this flexion contracture will be probably not the issue for us. So, to the conclusion, AMC, it is severe and variable restriction of joint movement and locomotion. Surgical treatment is necessary to enable active life in otherwise normal children. Joint contractures and muscle atrophy in AMC don't allow the restored full range of movement by any treatment method. Relapses are frequent, but we believe that transfer of pectoralis major muscle allows the established bilateral effective flexion elbow joint by retaining sufficient active extension, and we postpone this method also to the adult patient if we have this adult patient. So thank you very much for your kind attention. Questions? Can I ask you how many patients do you have here in Pakistan with arthrogryposis? Or is somebody here, Professor Bhakti?
In our practice, if we have the 12 cases or 10 cases of daily pediatric orthopedics in a week, it is 50, then 3 or 4 of the arthrogrypotic. Mm-hmm. We do surgeries, particularly to the extension tricepsplasty. But not I have not chance of transferring this pectoralis major. But in lower limbs, yes, we do the osteotomies and the release procedures. And I have a good chance of doing the carpectomy, particularly for the wrist, mm-hmm. For the extension. At the same time, a limited max page operation for giving the length to the flexors. And these 3 kids were operated at the age of 4 years. And they are doing very well, particularly, and have limited flexion of these because of they have a good flexion passively, but not so active. So we do have a number of the cases, but distal arthrogryposis is more common in country. And if Javed Iqbal is here, a good experience, and always he's presenting cases. Javed Iqbal? Yes, Salik? Yeah, he has been with the Javed, and he has done too much. Salik Kashif.
Thank you much, sir. Thank you so much. Yes, so we see a lot of arthrogrypotic patients and upper limb problems as well. So what I usually tell my parents, my patients and my students that below the shoulder, we can do a lot of things for the patients. When it's proximal to the shoulder, then we refer to specialized centers. Mm-hmm. So we do a lot of muscle transfers and osteotomies for these patients. And yes, we have some 2 to 3 years of follow-up. We relatively started recently, and patients are doing well.
Thank you.
There's Professor Chima here, Professor Tahsin Chima. He oftenly do these upper limb surgeries in the orthography. Yes, Saqib from Peshawar.
I don't hear.
Thank you for the nice talk. I wanted to ask about people who are arthrogrypotic and having spinal deformities, especially scoliosis. Nowadays, there is loads of development in treating scoliosis, especially the idiopathic ones. But I have seen a patient who had normal curvature up till the age of 13 years. He had other deformities in the knees, in hands, but he was quite well with his life going on. Later on, after 12 years, he developed severe scoliosis. So would you recommend a surgery for a patient who is having a good physical life and having this deformity only in the spine.
Yes, we will recommend it and treat it like the neuromuscular scoliosis. But it is another issue. I'm not a spinal surgeon, but we do it. If we see the severe scoliosis, we do it the surgery. Okay.
One comment, please. First of all, we come across a lot of cases of arthrogryposis multiplex congenita. Unfortunately, we do not have a registry, so we cannot tell you the numbers. But if you say you had 30 people in the Czech Republic with a population of 10 million people, so you can imagine with a population of 240 million people, how many cases would there be? But as Professor Bhatti said, that most of the cases we come across are those involving the lower limbs. And they have these knee contractures, they have developmental dysplasias and talipes equinovarus.
Yes.
So that most of the time we have to deal with them. There are specific people dealing with the upper limb, and I have dealt with a lot of cases. I do a quadricephaly, a modified quadricephaly for the knee joint, but I haven't done anything in the upper limb.
Thank you for your comment. One more.
And the sequelae of the upper limb in orthogrypotic patients. But may I ask a question regarding the ankle and foot in orthogrypotic patient? May I ask, please?
You mean the club foot?
No, sir.
Distal
Distal
arthroplasty.
Yes, sir.
Yes.
Sir, if the deformity of the foot is not being corrected by the Ponseti, although they are not corrected usually, and the patient presented to someone is loss of motor and sensory, should we attempt for the corrective surgery or should not be? What is your experience, sir?
This is a very good question, thank you, because in literature it is described that it is possible to correct the club feet in arthrogryposis. I will say no. It is not possible to fully correct like idiopathic club foot. So in these cases where it is not corrected, we make the really the pantaleal release, McKay procedure. We use it. We still use it, this procedure. Sometimes even the thalectomy, if it necessary. And it is relatively good for the patients for the function.
May I allow to have a comment for this?
Yeah.
Okay, in the killer foot, particularly in the arthrogrypotic, I have an experience, you are very right, and professor has also rightly said it is not, but it is possible in early stage you do the manipulation, get the corrections, maintain the corrections. Relapse is common. To relapse before it becomes severe, do recasting, and sometimes you need extended posterior release. I usually don't do the posterior medial, extended posterior release. You need to lengthen the tendons, and at the same time, if child is 2.5 and above, you can transfer the tibialis anterior to the cuneiform, and that behave good. Even then, in the long term, because muscles don't pass with the bone, so there is chance of the recurrence, and you have to maintain the manipulations, the exercises, and bracings. So that behave good. I think this is my opinion, sir.
Okay. Okay. Thank you.
The next talk is Shoulder from Inside Out by Dr. Sami Khan, UK.
Assalamu alaikum and good afternoon. Thank you, Faiz. Faiz was my senior. It has been a pleasure to be in your home country and attending an international conference, and that for the first time. I'm very thankful to my seniors, juniors, and the organizer of the conference for giving me the chance to talk to you today. I have my teachers here. Without their guidance, help, and I won't have been here. Some of them, they know me. Some other in the panel probably don't even know my name. Sir Khushnud was my teacher when I was a medical student. Sir Zahid Askar, Muhammad Ayaz Khan, They have been my mentors. So it's a pleasure, and I'm so excited to be here as a part of this gathering. And one thing that I would say, I'm not from UK, I'm from the Republic of Ireland, and we don't mind it because we are the part of Greater Europe, and UK is no more the part of Europe, so here we go. Just a few things. Let me just see, how does it work? Yeah, so my disclosure, pertinent to this talk, it is irrelevant. I have no disclosure. I have been a part of a few projects. They are not related to this talk. I'm kind of a little bit cheating on this slide. I have made this slide for 15 minutes, and then I got the liberty looking at my previous speaker. They have excellent support talks, so I kind of added up a few more slides at the end, and I will take them as an overtime because we are used to overtime and we are getting paid for that. So hopefully you guys won't mind it. But this would be kind of the layout for the next 15 minutes and a bit of an overtime as well. And in advance, I'm apologizing for that. Why shoulder? Why shoulder and upper limb as my choice specialty? My talk just before that, it would be kind of a mix of everything. I'm not going to present my research. I'm not going to talk about something very fancy. I'm going to talk about something very basic for the junior, something on the other spectrum. I'll talk about a mix of things. But why shoulder? The first picture, the further from the source of water, the more likely the land would be barren. Here, the source of blood is very near to me, to my working place. I'm so happy to have the blood pumped around the shoulder, which is minimizing my infection and other complication rate. Foot and ankle is a nice specialty. It's miles and miles away from your heart, near to the ground, with all the bugs jumping up a day later when you are allowed to walk on it. My shoulder, though, I'm sitting on the top of axilla, not a very clean place to be in, but yes, I'm away from the ground. And the other reason, most of us don't do what you can see there on the far left of this slide, and that's why I can even put my prosthesis upside down. And you know what I mean. A reverse geometric shoulder replacement, would you imagine to work in the hip? Not at all. Isn't Sir Khushnud? Would you think about reversing the hip if you don't have your hip abductors because you're walking on it? I'm just going to talk about a little bit of the basics of arthroscopy, especially shoulder arthroscopy. It's kind of, when I was a trainee here in KP, in our hospital, Sir Zaid was doing a few shoulder arthroscopies, and there were very few people who were doing it, and it was something very sophisticated, very advanced. We were thinking that we are not meant to do that just because things were very, they were very fancy. They were, even in the world literature, if you say things are very, so I'll just talk about some few basics. This is my setup in theater. When you enter the theater and the patient is not here, you see things there. My monitor there, everything, that's how you see it. B-chair lateral position, I use both of them. I'm using my lateral position for my cuff repair, and I'm using shoulder stabilization in B-chair. Most of you guys who are practicing shoulder, they are doing the other way around. I have my own reason to do so, and if I'm asked, I will explain the question, but that's how I set up my patient. You can see the patient there in the lateral position for cuff repair. You don't need the gold to glitter all the time. So you don't need a very fancy, traction spider, costing $1 million PKR, even I don't know, but it's costing 30,000 euros. So you can use simple little things. I'm using, in the advanced world in Europe, water bag for my traction. Simple little thing. Fluid management in arthroscopy is the key how you do arthroscopy. There are a couple of reasons for that. You can't use tourniquet, and the other thing is that subacromial space is a space with no boundary, no epithelial lining. The fluid just start extravasating. So this is one thing, so you have to be cautious about fluid management. You have two friends. Your anesthetist on the top of the table. If he has any begrudges with you, you're ghost. You need to have systolic BP very low, mean arterial blood pressure very low, and the other thing is your pump pressure. You have to have a very good control of your pump pressure. Portals are of immense importance. If you it's like looking into this room from a tiny hole. If you strategically make that hole, you will look at around very well. But if you put it in a way that it is not in the proper place, you are again, you would be missing a lot of information. I'm not going to talk about how do I make my portals. What can you do with shoulder arthroscopy? I'd say I can just explain it. Shoulder arthroscopy means as if you are jumping into the sea and you are start chasing the fishes and you start catching it because your eyes are within the giant. Some of you guys, I know all my senior teachers, and they used to do open cuff repair. Open cuff repair sounds good. It's a difficult procedure. I have done it. It's really hard to find it. But if you jumped into the shoulder, like this guy in the middle of water, you can roam around, you can see everything, you can see from upside down. So, and open procedure like that, you are standing out, you're just sending your hands into the field. These are a huge list. Sorry for the busy slide, but that's what I'm doing. Arthroscopic cuff repair, arthroscopic subacromial decompression, arthroscopic acromioclavicular giant excision. I do tuboplasty, I do bicep tenotomy tenodesis, I do Bankart repair, arthroscopic shoulder stabilization, I do remplissage, I do slap repair, I do dynamic anterior stabilization using long head of biceps. I'll just play some videos of this as well. And just a little bit more fancy things, I do use page augmentation for very huge rotator cuff tear. And at times, although the literature is not very much on my side, I would put some balloons in space if they are indicated. What are your limitations? The most important thing is your speed and accuracy. You are not doing an open operation. You are not doing an open procedure. You don't have the time on your side. If you don't run with the speed, if you don't finish it quickly, it will balloon out on you. The shoulder will balloon out on you like that. And then what you see is here. And then if you are doing a procedure, that you have to fix few things, because when I am doing any procedure on my patient, especially the high level athletes, rugby player, I do consent to sort out anything that I find inside. And if you are doing something less important and you waste your time and the shoulder is swollen, you are left with your important business and you are looking things like that. So time is money, and you need to be very accurate, precise. You have to have the calculated your time that what I need to do, and if things turn on me like this, what I can live safely. So say, for example, you're doing an interior stabilization, Bankart repair, and at the same time the patient has maybe interior cuff tear as well, which is very small, minor. You can just do it in another procedure. You need to stabilize your interior, shoulder first. You need to do the Bankart repair rather than spending 2 hours on an hour and a half on sorting the cuff, and then when you're down to the stabilization, you don't see anything. Just for the juniors, would you be able to play this video for me, please? Yeah. Sorry, guys. Can I have your attention for a second? Can you play the video for me? Yeah. So just quickly, and if you have the control, kind of speed it up. That's how this for the junior slot, that's how I do my shoulder arthroscopy, long head of biceps. Obviously, this was anterior labral tear. So I do, look around. I look at the giant surface. I jumped in to look for any Hagel lesion there. Oh, thanks. Oh, God. Are you guys still with me? Okay, yeah, so I just posterior labrum looking okay in here, giant surface looking good. Just for the juniors, you need to have a system for the diagnostic arthroscopy. You can't jump around places because you could miss a lot of important information. Band cut repair, I do using freehand, so just kind of a couple of picture I will show. So this is again interior labral tear. I'm using these clever passes, we call it Sixter, and you could see it. Okay, so I'm trying to kind of pass the first suture. I'm going to grab it with my clever hook, and that's, again, if your BP is kind of on the higher side, you won't see things so clearly, and you'd be in trouble. This case, I'm not sure it's the same case. In another case, I have a guy with a deficient labrum. I'm using MGHL, that is the middle glenohumeral ligament, as an argument. So you can see there, this is the tear. And if you see there, after liberating the labrum, there was less left, so I grabbed this MGHL, that is the middle glenohumeral ligament. Most of these people, they are hyperlax, so I don't mind if they have a little bit of external rotation leg, if they do get it after good physiotherapy. This is another example of remplissage. So if you do, I'm not going to fall into the detail that when I'm doing remplissage, but just I'm preparing the heel sac with a shaver. You're just going to denude it. There is some tissue, so I'll just going to clear it out for good healing. I'm going to put my first anchor down there. The anchor is down, and believe me or not, they were very fast. They're kind of getting slow in here. I didn't want you guys to be bored with some, so there is the second anchor going down there. And then I've already grabbed them out, so now when I tie them in, that's what you get. That's what you get after the remplissage. So I have some other procedure. Routinely, I do a dry shoulder scope arthroscopy before my open latergy. I don't do arthroscopic latergy, I do open latergy. I do, at times, very few cases, this is looking a little bit kind of mad adventure if you're doing remplissage along with latergy, because you are obviously doing arthroscopic remplissage before your latergy, and you are kind of flushing the shoulder with fluid and swollen for the latergy. But yes, I have done kind of 10, 15 cases, and we are going to publish our case series on that. Subpec pectoralis LHB tenodesis, I'm just going to go in there, diagnostic shoulder arthroscopy, take down the long head of biceps, and then I come open, do subpec open bicep tenodesis. ACJ stabilization, I used to do a lot of like kind of arthroscopically assisted stuff. I'm completely now on the open side. I just don't do it. So just kind of small Beckany type incision, and I don't put a scope if I don't need to. Lower trap transfer for irreparable cuff repair. Yes, this is again a case series that I'm going to publish in the next few months. Some 10, 15 cases that we have done it. This is my overtime. So this is, my talk is over. Officially, if someone has, you have the liberty to take me down if you want. So, but I'm not an arthroscopic surgeon only. I do shoulders trauma. I do upper limb trauma as well. I didn't know that I had to present in an arthroscopy session. So what proximal humerus fracture, what is my approach? The gold standard approach, deltopectoral approach. I used to do McKenzie split stuff. I'm completely off all those things. I'm doing deltopec approach. When to fix and replace, I'll talk about that. And I have some adjuncts to my proximal humerus fixation. I'll talk briefly about those. This is my approach, how I use my delta Pak approach. This is for the latter J. Obviously, if I'm doing reverse geometry shoulder replacement, or if I'm doing proximal humerus fracture, I orient the incision more kind of obliquely, not so straight down. The size would be a little bit more higher, bigger than this. It may not be so. When I'm fixing and when I'm deciding to replace, if I have a fracture, oh God, okay, here we go. So if I have a jig puzzle and a lot of complex fracture, in US, Europe, people are intending towards kind of replacement, reverse geometry shoulder replacement. If I could put together jig puzzle, and if it is even like below 65, I'll fix it. And if it's not fixable, and if I get someone like there, this part of the world, you don't find, smoking, but on that part of the world, smoking, drinking is a common thing, and elderly people, they do smoke as well. I don't prefer to fix them because they are going to collapse, they're going to get AVN, and I have to do them again, and unfortunately, their lungs are not too good to get another general anesthetic. My adjuncts to shoulder proximal humerus fracture. So I do liberally use cortical strut grafts. They give you a good scaffolding to hold the humeral head and stop it from collapsing. And so you can see it here in this picture. This is strut graft used here. You could see it in here. I don't mind if I have a small little bump there. My arthroscope is there. If I see them, I'll come there and I'll share it later. Because of this issue, I have this cement. I think the hip surgeon, they were using it for trauma, like if it is osteoporotic bone and you are worried about a DHS cutout, they used to use this, but I started using it in my fee losses as well. So they are this cannulated screw, and I do inject the cement. You can see it here, and I have good results. Not a huge amount of cases, maybe just few cases I have done so far. Shoulder arthroplasty. I'm not going to mind you guys for too long. These are all my options, but my biggest thing that I will sell it out is my reverse geometry shoulder replacement. Stemless anatomical, stemless hemiarthroplasty, and hemiarthroplasty I haven't been doing a lot, but yes, most of my business is reverse. So these were my anatomical. I have this stem anatomic. You have a stem, and you have a glenite there as well. I've kind of drifted from this kind of configuration. I was using this Arthrex one. It was a good one. Very lately, I'm kind of getting to this thing. This is European implant Matthews, so I'm using this. It's a stemless implant, and I'm using this stemless ceramic head in a very young avian collapsed head with good glenite. I'll just use stemless ceramic head without touching the glenite. All this is one-stop solution for all this problem. Is obviously there is one thing missing, is the irreparable or unreconstructible fracture. I'm using reverse. So cuff arthropathy, failed anatomical, fracture dislocation, unable to reconstruct, failed fee losses, ORIF, non-unions, failed cuff repair, and GT dislocation. My go-to is a reverse with minor detail. I know Sir Khushnod is holding the mic.
Yeah, one more minute.
Okay, sir, I'm going to leave it there. That's there. I'm not going to play this video. Okay, rehab. I have my physiotherapy colleague. They will talk to you about that. This is one thing. Whenever I'm presenting anything internationally or in Ireland, I do sell my country there. So I thought that I will sell my country, that is Ireland, here as well. And that is a place that is just a kilometer away from my home. I do go there and run. And I was wondering if I get any of you guys there for any, reason, I won't mind to take you there on this jog. I do offer this to my Irish colleague. I will show them Karan, Naran, and Waziristan as well. That's my homeland. But to you guys, yes, this is a place away, a kilometer away. It's called St. Catherine Park, and I could take you there. And that is an offer to my junior colleagues. If you are interested in shoulder or shoulder arthroscopy, this is an offer if I could give you. Obviously, you can't do hands-on fellowship with me unless you are registered with the Irish Medical Council. But if you want to come over there and just observe and just see things, you can enjoy the walk there as well. And you're more than welcome. Thank you very much. I would like to have any question on board.
Any questions?
Thank you very much.
Thank you very much.
Bismillahirrahmanirrahim. Now, the last talk of this session, it will be a little bit different. Hope you would like it. Islam favor acquire knowledge, and transfer of knowledge is a sadqa jariyah. So the title of my talk is Tips and Tricks of Writing Original Research Article for Impact Factor Journals. I have no conflict of interest, no grants, funds, or support received. Knowledge isn't free, you have to just pay attention. The outline I'll be discussing shortly: the learning objective, learning outcome, the manuscript submission journey, impact factor and its significance, anatomy and physiology of a research paper, some reporting guidelines, AI, artificial intelligence tools, and the commonly made errors in article writing. The learning objective: by the end of this presentation, I expect that the audience would know the significance of publication in impact factor journal, that why to publish an impact factor journal, and understand the components of a research article and avoid errors in research article. The outcome would be you should be able to write a good quality original manuscript that is appropriate for submission to an impact factor journal. Now, this is the scholarly tree. As you can see, after collecting the data, and now it's time for it to publish, and you want to climb. Publication is just climbing a tree. So you can see it's the author, the reviewer too. These are obstacles. He's cutting him down. The editor, the role of editor, and the reader. If the reader is not interesting, you would not read your article, and your article will not get citations. And even after publications, if some ethical issue is detected in your article, so your paper can be distracted. Usually, when you submit an article to an impact factor journal, a minimum of 2 reviewers or 3 reviewers it is sent. So the reviewer second, it is known that he is a little bit strict, reviewer 1 is lenient. So the reviewer 1 is the real threat. You can say that he would reject your article. On what grounds? If you don't know the writing principles and guidelines. Sorry. So that's the scenario when we have after data collection, when we have data in our mind and we want to publish. We have a cool research paper, but on paper we don't have any guidelines, so the picture is like that. And when you submit to Impact Factor journal, then you're waiting for the editor or the reviewer decisions. So paper according to the author, and you see it's in your mind, you said that I have submitted a very good quality papers, but reviewer too can see that it is his imagination, that it is assessment that your paper is not good. That's reviewer one, and I told you the reviewer one, he is a soft-spoken, a lenient, and you can see the reviewer two. The reviewer one, it's usually he supports you, he facilitates you, but reviewer two, he is not that much good. And when you said I'm fully prepared, but you can see the reviewer two comment, you are out on the first. That's a pictorial presentation. The reviewer one that usually asks you just a minor revision. Reviewer two straight away reject if your paper doesn't follow the guidelines, the principle. Reviewer three may say major revisions. And that's the reviewer profile, and when you submit, it's a nightmare of manuscript rejection. You send successfully, but after reading the comments, you are like this. And sometimes when you do all the corrections in your papers, so you can expect this. And after addressing the reviewer two comments, add submission and after rejection. But this is not a failure. You must practice, you must learn the guidelines, and you can see that success is not that what it looked like. Behind success, there are sacrifices, risks, criticism, failure, rejections. So rejection is for anyone to grow up, and it's an opportunity for you. Now we will come, if you look at any journal, you would find two types of articles. One is the primary research, that is original article, surveys, and case report. And the secondary, you can have narrative review, systematic review. Today, our is original research article. I'll be telling you tips and tricks how to publish your article and original article. As you can see, this is on the base of complexity, that which one is difficult to write. You can see letter to article is the easiest one, communication is another based upon the difficulty level. So your case report, case control, original article lies somewhere here. In the review literature and randomized control type, they are technically difficult to write and then difficult to publish as well. Now, why we want to publish? So, as you can see, publication can be a study requirements, it can be utmost needs, it can be academic careers. And if someone is trying to have top rank position, for that also you need, and if a friends, colleagues, and science community. So these are all motivations for writing an article in publication in Impact Factor journal. Now, this study shows that the most important factor for publication is dissemination. You want to disseminate your information, your findings, your study. Then for about 20% of the people, you have career prospects. That is the first choice. They want their career, and for that they publish their papers. Then for fundings you need, then for ego, then patent protections, and then some for other choice, they have their first choice. Now, this is another, you know, when you publish, when you do some original research and then you publish it, you know, it would take 17 years for an average of 14% to translate into practice. They would be then translated into systematic review and meta-analysis, and then your research might have been used as a guidelines, and people will follow it and people will practice it. So that's another aspect of publications. Now in KP, we were at rest when suddenly you might have a Medical Teaching Institution Act. And in that you can see they have a criteria for 30 marks. And impact factor, if you have publication in any journal which has impact factor 2, so you will get 5 marks. And impact factor 0.32, less than 2 marks. 0.1 to 0.3, 0.5 marks. And HEC, they have 0.25. So you can see impact factor journal, it carries, they have given it a weightage of 5 marks. And maybe this criteria is still over there, maybe it's later on in the coming years, maybe it is adopted by PMDC as well throughout Pakistan. So it stresses the need for you to publish in impact factor journals. Now what is an impact factor journal? Simply, impact factor journal is based upon the impact factor, which is calculated as that it is actually of the last 2 years. Publications, citations of a journal last 2 years, and publication of total articles. So it gives you the impact factor, and it's actually the number of average citations in that 2 years. And it is after every year of the last 2 years is published by JCR, Journal Impact Factor, Journal Citation Report. It is available on net. You can find it, the original. And one thing, remember that many journals have in their website written the impact factor. Please do check in this checklist. This is the original one. If you want to publish your paper and impact factor, first just check this list. It is available. You can see this is a print form. Then you have HEC website. You can also check the authenticity or the impact factor of a journal. So it is a Higher Education Commission. It's a screenshot of that website. So you first check over there. And now, luckily in Pakistan, this year we have 12 impact factor journals. Last year we have only 3, so you can see their impact factor. These are the 12 biomedical journal. If you want to publish your article in impact factor journal, I would advise you first try this. First try for this is our country journals. They are authentic, they have impact factor, and the minimum I show you for promotion or for anything. Then you can go for other impact factor of higher rank like JBGS, but first do try this, and this is the genuine list. You can find it on HEC website. Now, as you can see, this is an academic cycle. You have collected the data, all steps have been followed. Now you want to write or draft your paper. So how to write it? So journal selection is the first criteria. Do not write the draft until and unless you have selected the journal, because your draft, initial draft, depends upon that journal criteria, what they want, what are their publication guidelines. So the first step after collection of your data, completion of your study, you first see the journal selection, the list which I have shown you in impact factor journal. You first try that. And then there are certain rules that which journal you should follow. So your aim should be a higher impact factor journal, right? Many journals, they have they provide opportunity to you. You email them or you preliminary submit your abstract and ask them whether my abstract is can be published in your journal. If they say yes, then you can publish it. And then you can send in the draft. So the first step is always see the author guidelines. You see these are available on every journal. They have a website. You go there and you see the journal guidelines, because it will give you a scope of the journal, whether your study can be published, format of the article. That's important. That will give you how you write. You should write title, abstract, heading, words, keywords, type and size of font, table, graphs, word count, references, all information are there. So you first and go there. Now, writing an article, there are 4 essential questions. And each question is actually a part of that article. First, why did you did this study? So this is, you write it in introduction. How did you do it? So these are the methods. What did you find? The results. What does it mean? The discussion and conclusion. So there's the famous format of an article. You start with introduction, methods, material, results, and discussion. MRED. So that's it's applicable to almost all of the impact factor journal. You write in this format. Some journal might have a letter instead of methods. They have methodology, material, and methods. But the basic format is the same. So again, if you can see how you would should write your introduction. So you would start from journal to specific. It's like an inverted triangle, and in the discussion, it's upside down. You start from specific to the journal. Now, this is again the MRED format. you can see the title has been added. Despite these 4 basic components, you write the abstract, that's just like a head. Then is the abstract is the head, and the conclusion just like the feet. It's again the same format of an article. Now, it's the anatomy and physiology of an article. What does its introduction mean? Its function is why did you do it? Right? The rationale of the study you have to give it, and it motivates actually the readers. Then is the methods. How you do your study, your procedures, enables the replication. Its function is that anyone who can do it can replicate your finding, your study, your techniques, your procedure. Then the result, what did you find? Share the data. The goal is to share your data. Discussion is actually the significance of your study. You discuss your significance and you suggest interpretation. Acknowledgement is optional. Acknowledgement is optional. We help you give thanks, references, source cites, give credit for the previous studies on the same topic. This is another format, just like title, abstract, introduction, methods, results, and discussion, conclusion, and acknowledgement. Now the first part is the title. So what should be the characteristics of a good title and a catchy title? So making your research paper discoverable title plays the winning trick. So you can see this is not only the, it's actually a title, a good title. You can see the number of words and the columns, you can see. So this is an example of a good title. Your research title should be like this: appropriate, educate words, colon. Later on I'll show you that some titles are good, they have good citation abilities, so using colon is one of them. So you can see the title is actually the first thing which the readers they study, and if they found it interesting, they would then be able to read the abstract or the rest of the article. If not, they would skip. So it shows the significance of article. The next is the abstract. If abstract is interesting, they would read your paper, otherwise they would skip it. And moreover, this you can abstract and title. They are free of charge. I mean, it's available on every website. Some website, if you want a full article, then subscription based, you have to do subscription. So these two are freely available, the title and abstract, and these are the key for the readers to go down to read your paper. Otherwise, they would have skipped your paper. So the title is a label of paper. So the educate length, it should not have more than 16 or at least 20 words. No longer titles, they are recommended. Abbreviation, they are usually avoided. You can use standard abbreviation like WHO, but it is better to avoid it. It should be concise, clear, easy, conveys the important aspect of research, and usually in one complete sentence. Then there are some journal guidelines which would tell you that you write all the capital letters, but some journal guidelines have less capital. Okay, I'll go quickly. Then the types of titles, you can have declarative, descriptive, interrogative. These are types of title. Some words that are waste word, try to avoid those. A and D, in effect, these are the waste words. So you better avoid it because they are not useful in citing your research article. As I've told you that impact of a title, if adequate title length, concise title and use of colon, they are used if they have good citation abilities. So try to have adequate length and concise title, and if use of colon, that's an option. So your article would have good citations. Errors, we usually do not have, the title is not smart, too long or too short, not consistent with the subject or rationale. Use of colon and slash, use of waste word. Okay? Now we come to an abstract. You can see half of manuscript at high impact factor journals are rejected based upon abstract. Abstract is not good, so your article would not be accepted. Now there are certain journal guidelines, and abstract should be either have structured or non-structured or visual. So it's an example of a structure abstract. You can see objective, conclusion, methods, and discussion and conclusion. This is an example of a structure. A structure should be like this. Again, a structure. So you should have initial components. And this is an example of a abstract with non-structured. As per guidelines, a little bit lengthy, but it's per guideline. So it do not have any subheadings in it. Now, some journals have started the visual abstract. So that is per guidelines that they use just visualization, no much text. Errors, incomplete format of the abstract, copy paste from text, citations included, and omit primary find. These are the errors which you must avoid it in writing an abstract. Now, the next most important is study objective. We usually have not exact or specific subject objective. So these are the guidelines. It's based upon the research question. And your study objectives should be specific, measurable, achieving, relevant, and time-bound while you are writing it, the draft. The research aim and objective, they should have been in coherent and one thread, right? Keywords. Keywords are actually 5 to 7 words that are used after the abstract. They are for indexing purposes so that anyone who can replicate your article, who can locate your article and the word. Now, what should be, you can find these keywords in Meshword, or this is the website, you can find it over here, appropriate keywords. And this is just an idea that how you found your keywords. So you first identify, these are for mesh or for a similar article, then you select 3 or 4, and the last or the final keywords, they are 3 or 4, they are usually in alphabetical order or in ascending, you code them. Errors, they are missing keywords, wrong keywords, term abstract keywords not in order, and sometimes you use abbreviation in the keywords which are not acceptable. The next section is introduction. It should have been 10 to 15% of total word count and usually less than 5 references, but not more than 5 years old, 5 to 10 references. That's how you write your introduction, from journal to specific up to the rationale. That's how you write your introduction. From journal to specific, from known, that's depend upon your study objective and your study topic. The discussion, you write it in the first paragraph, you simply write what do you know about your topic. You are searching in a topic, writing, and then what we do not know. That's the research gap. And then why you want to conduct this study is a rationale. Now, the research gap, that's a difficult portion of the study. Many articles are rejected because the editor, the reviewer asks why you want to conduct. That's an important. So you look for gap in population, gap in analysis, gap in implication, gap in methods, concept, perspective, theory, right? And this you find through literature review relevant to your topic. Errors in introduction, material irrelevant to the purpose, right? Introduction is extensive review of literature, omits or vaguely describe the purpose, unnecessary long, okay? Not citing recent and relevant, preferably less than 5 years citation, unki references, rationale, aim and objective, research not indicated. Now we come to the next topic, that is the method of your article, how you write your methodology. The purpose of methodology is replication, that how you reproduce, anyone can reproduce your data, your study, your technique. So that's the method, and it's written in chronological order, logical flow from science, right? Now, these are the 7 portion of a method. Like first you would write the study setting where you did your study design, sampling technique, a little bit ethical approval and informed consent, and recruitment methods and experiments and statistics. So these are the 7 components. They must be briefly described in your method component. Now, collection of errors and methods. does not provide adequate information. That's no, if somebody want to replicate your procedure, he cannot. So that's the error which you should avoid it. Does not follow reporting guidelines. These are the reporting guidelines, like randomized for these are available on this Equator network. You can find it. For any study, they are reported guidelines, so you must write that I conducted my study as per those guidelines. It's essential to write it in the methodology section. The sample size. Okay, sir. You write about the sample size. These are the two tools from where you can calculate your sample size, write it in methodology. Type of statistical test, the important one, you must write it in methodology that I applied this test, and better to take an advice from biostatician. And this. Now these are some of the AI tools which you can have while writing your paper. Right? These are available, some are free, some are subscription based, but remember there are some ethical issues like this. So before using these AI tool, you must be careful about the ethical issue and try to counter those ethical issues and your disclosure. Now the results, errors in the result. Results are reported selectively. I mean, percentages without frequency, standard deviation, confidence interval, methods and discussions are included in the result, repetition of the same data in table and graphs. So these are the errors which we should avoid it. Errors in tables. Remember, if you have more data, you use table. If less, then you do not use, you just write those in text form. Now the discussion should be concise. It should go from specific to journal. It's again key results, study findings, and like in the lower down, you can have generalization or external validity of your results.
I would advise to please conclude. Noah's time is getting very close now.
Okay, sir. Okay. Thank you. Thank you. I would request the panelist, Professor Khalik Ahmed Siddiqui, Professor Khushnood Alibas, and Dr. Zulfikar Jatoi to come to the stage for presentation ceremony. I would request Professor Nazri Mahmood to come to the stage and receive her shield. I would request Professor Muharram Inan to come to the stage. I would request Professor Chomek to come to the stage. Dr. Sami Khan.
Now request Faisal Isha to receive the shield. He is the ex-editor of the Journal of Pakistan Orthopedic Association.
हाँ वापस कर दी वो वहाँ पे पड़ी वो भी वापस आएंगे
हेलो 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 हेलो
Regarding the format of the session, first there will be 2 invited talks, and after that there will be free papers. So for the first talk, I'll invite Professor Nazri Muhammad Yusuf, and his topic is problems and solutions of using external fixator in the femur.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Welcome everybody to this afternoon talks. Today I will share with you some of the problems and solutions using the monorail external fixator in the femur. So I know some monorail is not so common here in Pakistan as compared to my country, but I heard some of you have done a few. So I just share my experience using this device. So as you know, the monorotor external fixator is not stiff enough to control the strong deforming force, especially in the femur. However, the circular fixator is strong and stiff. However, a little bit bulky, and it's quite difficult for patients to rehab and to sit or to lie on beds. So in this case, the right femur is using the Elizarov system. On the left is the monorail system, if you can see properly. So the monorail fixator actually gives adequate stability and, more importantly, more comfort for the patient to lie on bed and also to sit on the chair. So this system actually also developed in Italy by Prof. Di Bastiani from the Verona Institute. And this have a clamp and also a CDU unit which can lengthen or shorten the device. So its indication is mainly for fracture fixation, but also can be used for deformity correction, which is not so complicated, and of course for bone transport or bone lengthening. So this is an example of a normal, the common use. If you use the normal external fixator on the right there, you see it's usually, you need to put the screw near to the fractures and near FAF concept to give stability. But if the pin is too far, it's difficult to get the stability. But the LRI system, it somehow allows, even though the screw is far apart, it gives some stability as compared to the usual fixator. Because of the monorail are more thicker, and then the clamp are more stiffer. Of course, the LRI system can also use for definitive. For example, in this patient with severe open femur fractures, so once the swelling have subsided, we were able to close the wound secondarily, because the femur with a lot of soft tissue, actually you can really close it if you try, but make sure it's not in the, the inflammatory stage is up, and then after 2, 3, 4 days it's coming down. So you want to suture when it is the swelling is subsiding, not when it's going up. So and then after that, we stabilize this patient with a monorail system. And then in this case, we also add the antibiotic pellets that we have at the time. And this boy have actually an excellent result after 5 months of injury. And I think the other good indication is for lengthening, because this is easy because the bone is not fractured. So you actually put the rail on a not broken bone. So it's so easy. So good for starters. If you want to try this, try lengthening first. So in this case, this is a neglected fracture. As you know, this patient has deformity also, which is a bit complex, but he came to us mainly for limb length discrepancy, limping, and also back pain. So he just want to make the leg equal. So the best thing to do is to choose to put the rail on the normal side. So basically you see here, I choose the distal because it is straight bone. If I put the screw on the proximal and distal, then it's difficult to fit in the rail because the rail is straight. It's not like Ilizarov where you can put the screw anywhere you want. So once we did the lengthening, it's quite straightforward. And we managed to get the length and alignment. Okay, on the coronal view. So this system also can do some sort of deformity corrections. In this case, you see we have varus deformity and also some anterior angulation. But we decided to just correct the varus deformity because the anterior angulation is mild, and then our body also can compensate the sagittal alignment, malalignment. So in this case, we can correct the varus deformity by using this. We do osteotomy at the normal side. Don't do osteotomy at the fracture side because a lot of callus and the bone is so big. And when you do osteotomy there, you can end up with a lot of bleeding. So I prefer you use osteotomy at the normal bone. It's much easier. And then we have this special clamp to adjust the varus and valgus corrections. If you not accurate, you can still adjust with the special clamp. So this is the X-ray pre-op, and post-op you get the correct mechanical axis. Actually, if you are good at it, you can still do a multiplanar deformity correction. For example, in this case, neglected fractures. First, we want to correct the varus deformity. The key is to put the screw at the right angle to the anatomical axis of the proximal fragment and distal fragment. And once you did the osteotomy, the bone will correct itself because the screw is initially put on the slanting, and then you cut, it becomes straight. So on the lateral view, it's anterior angulations. You put the clamp parallel to the shaft of the femur on the lateral view. So similar, initially like this, and when you cut, it becomes straight. So you correct the varus and also the anterior angulation. And also external rotation, also you can do also with this device. The first proximal screw you put parallel to the floor, and then the distal screw you put a little bit oblique, and once you cut the bone, it become correct the external rotation. And once you did that, and then you can do lengthening as usual. The other indication is for bone transport. I think this is quite similar to other device. For example, in this case, a patient with severe femoral fractures, initially treated with the conventional external fixator until the wound has healed. Once the wound has healed, then we can apply the Ilizarov fixator, and then we do bone transport for this case, from distal to proximal. And then once it's docked, we did the bone grafting together with some bone substitute. In this case, we do it slower than the usual rate because the injury was very bad, so we do it a bit slower. So the problem with the monorail system is it's a straight device, and it's very difficult to do it if the fracture is at the distal, not at the shaft. So for example, in this case, the fracture with distal femur, so when we put on the LR monorail system, a little bit difficult to get at the distal fragment, and you can see the screw goes into the joint. So we need to revise it with the ring fixators so that we can get the alignment. This is the picture of the device in close-up. So basically the monorail system, and then this is the circular system, and then this is the connection, the hybrid connection with, for the monorail and the circular fixator. So by using this method, we can get the bone transport. Another example, post-fracture, open fracture femur are treated initially with the cement, antibiotic cement. And then we did bone transport for this using the hybrid fixator. And then this is the example because initially we thought that we don't have to extend the fixation to the leg, but the patient find it very painful because the distal fragment is very small, so it's painful. So we add on this extension in the ward because patient already out of the OT. So by putting this sling, actually it helps to reduce the pain easier for the patient to nurse. So in this case, he has achieved a good uni and result. So the monorail system also can be used for spanning hybrid frame from the femur to the tibia. In this case, we use this because this patient has distal locking plate infection. So because the plate extends from up here, so you don't want to put the screw at the infection site. So that's why we choose this device rather than the Elizarov device. So there are also problems with this device because this is a monolateral system. If you do lengthening for long, then it will tend to go to varus deformity because the monorail system is on the lateral side. When it gets lengthened longer, then it tends to go to varus. And then if long lengthening, so the regenerate takes very long time to harden. So this patient ended up with deformity. Actually, he didn't complain of any pain. He just noticed that his leg become shorter and a bend. Because it's not really fracture, it's like the regenerate is soft, so the bone bend and short again. So you can see there is severe anterior angulation. So to correct this, we do chipping osteotomy. Chipping osteotomy because the deformity is at anterior angulation like this. If we do acute corrections, you will stretch your sciatic nerve because it's like this, and then you extend. And then this patient also have stiff knee, so that really is going to stretch the sciatic nerve. So by chipping osteotomy means you make the osteotomy very convoluted, so you don't lengthen so much. Understand? I think you got it. You're all expert surgeon already. So this one, another example of the complication is patient have a periprosthetic fracture. Initially, we thought it's not infected, but when we open, it's actually there is pus there. So we convert to monorail system and fibula graft, and we have loosening. This is one of the problem with big screw because this LR system have a big screw, 6 mm screw. And it's so big, if you have infection, it's easy to lose. So the key is to use the hydroxyapatite coated screw. So this really makes the difference. Always, if you cannot buy anything, just buy the HA coated screw. Because the monorail system, you can recycle. You can keep it in your hospital, and the patient donate it. But the screw, try to get the fresh HA coated screw, because it really helps to prevent this problem loosening. So for this case, because this is a mentally challenged patient, so we decided to use the femoral brace. And alhamdulillah, with a lot of dua, so this fracture united. And this patient was happy. Family was happy. Okay, the other problem is in young children, adolescents. For example, this case, we infection and then we do stage procedures and do bone transport. And after removing of the screw, the bone fractures at the screw hole. Because in young adolescent, the bone is small, the screw is 6 mm screw. So you can end up with fractures at the screw hole. So a solution is we can use the smaller screw, which is 4.5 mm for adolescent. And then the problem is it's small screw and you get fracture at the screw also. So you got to manage your rehab protocol if you use a smaller screw. Maybe you got it about the weight bearing. Okay, another problem is this device. If you use for fracture fixation, this is after 7 months of fractures, and on X-ray we think that the fracture already united, But during physiotherapy after removal, got fractures at the fracture site. So a bit difficult sometimes to see because once you remove the external fixator, there is no more protection for the fractures. Whereas if you have interlocking nail or plating, the implant is still there for many years. So this one, if you remove, there is basically no more support to the fracture, so it can get fracture if really not healed well. So refracture is a common problem for this device. So the short solution is can do nailing after the pin site heals. Or if possible, you want the patient to walk on it for a few months before you really remove it. So if the patient can walk on it and there is no pain and then the X-ray shows union, then inshallah, hopefully you don't get refractures. So ladies and gentlemen, the take-home message is this device is stable and comfortable for the patients. It's suitable for difficile deformity corrections and also for bone transport. And you can have this hybrid clamp for fractures nearing the joint or you want to cross the joint. And don't forget to use the hydroxy epithet screw to prevent loosening. And always beware of fractures after removal of the fixator. Thank you very much.
Thank you very much. Very nice talk. How frequently did you have to nail after this fixator? And second comment was the ability of this fixator to dynamize itself, to promote union. Is there a capacity in this fixator inbuilt?
I have about 3 cases of refractures after removal at the fracture site. But I don't really want to do nailing after LR fixator because high risk of infection. The problem is we thought the fracture is united because based on X-ray alone, it looks united. So maybe there is other ways to assess for union, maybe some device that really, a mechanical device I suppose. But if we are afraid that the fracture might refracture, maybe some people, they just remove the rail first and then don't move the screw. So if there is fracture, you can put back, maybe, but still need general anesthesia, I think. But sometimes I really put back the screws again because patient also afraid that they might have infection after nail. So some patients prefer again to put a fixator, but some who refuse, then we go for nailing. So I prefer to put the rail again rather than put the nail if the patient already on the rail for a long time.
Assalamu alaikum. I am Dr. Abdur Rahman. I have a question that you as already mentioned that the pin loosening is the problem, and the solution was the hydroxy epitite coated pins. No?
Yeah.
But the cost does matter. In our part of the world that we are facing a lot of pin loosening. What is the solution if you don't have a hydroxy epitite coated shanks pin?
Solution?
Or trick, any practical trick to avoid the loosening?
Which I haven't done. Okay. So basically, the rail is straight. So you can put another screw distal or proximal because the clamp is like this, like 6. So if this screw is loose, then you just move the clamp proximal and then put a screw, or distal and put the screw, because the rail limit your option. So you just can put proximal and distal. So you should give some space for you to put extra screw if it's become loose. If otherwise you end up with some modification, maybe put the hybrid fixator. Of course, the other way is this system. If you buy a complete one, there is a sandwich clamp. A sandwich clamp means it's like a double-decker clamp. So the initial clamp is here, and then you can put a sandwich clamp, which is like a double-decker bus. You can put on the upper deck. So I think cheaper buy hydrostatic screw than buy the sandwich clamp.
Can I ask, please? Thank you very much for a wonderful talk. Okay. Indeed, I am Dr. Nizami from Lahore. Mostly what are the studies and what are the recommendations overall that the internal fixation after the external fixation should be avoided?
Yeah,
but we, at least the old school, if not the new, what you are talking about.
Yeah.
Whatsoever, I would like to ask about that, is there some sort of infection after intramarollarly nailing with the replacement from the fixator to nailing?
Yeah, there is risk.
The percentage of the infection rate. Yeah.
Agreed. There is risk of infection, especially is very high if you are doing it for infected case. For example, infected non-union, you do a bone transport. And then if you want to do nailing after that, the risk is very high. So you must be ready to remove it any time if you suspect infection. And of course, if there is history of pin site infection, which is bad, then you probably don't want to.
Thank you, Professor Nazari. As we use a circular frame in the femur, it is cumbersome to manage it. With the uniplanar rail, monorail system, how you will manage the stability if you have pins far from the osteotomy site or the fracture site? So is there any effect on the stability of the two fragments?
Fragment? Yeah, of course, it's the same principle with the other any fixator. If you have a fixation which is near and far, then you have more stability. But the problem is this device is expensive. If you have a lot of money, you can put many more screws and extra clamp, because we want to cost money and it save costs. So that's why we use one clamp, because one clamp already expensive. But if you have a lot of clamp, of course you can make it more stable with 2 clamp above, 2 clamp below.
And if you want to make it hybrid, how many rings you can add on the same single frame?
Hybrid?
If you want to add a ring with your monorail system, how many rings you can put on the same frame?
So you can put how many you want, because the first ring connect to the rail, and then the second ring can connect to the ring.
On both proximal and distal ends only?
Can.
Okay.
But usually the proximal one is proximal femur, you cannot put,
Thank you.
Okay.
Thank you, Professor Nazri, for your enlightening talks. You discussed both problems and solutions. Now I'll request Professor Zamir Ahmed Sumru. He will be talking on principles of correction of multiplanar deformities. Sir.
Thank you, Dr. Ali. And thank you, Dr. Nazri, for your excellent talk. There was a pertinent question of Dr. Masood Umar, how to dynamize the monorail. So it can be dynamized by removing the distracting rod, and also you have to lose the clamp inside which is distracting. So that's how you can dynamize the monorail. So now I am talking about the deformity correction and especially the multiplanar deformities. Next. We have to see what is type of the deformity, what is natural history of making a deformity, what are the type of deformity, and the causes for a particular deformity. Then we have to see the methodology, how to correct the deformity, and then we have to follow the principles of Elizarov. So principally, there are 4 types of deformities. One is the angular deformities, translational deformities, rotational deformities, and limb length discrepancy of shortening and over lengthening. So these are the deformities which we come across in our clinical practice. As you can see, the common deformities, genu-varus and genu-valgus. Some sort of the complex deformities like this one around the knee, you can see the deformity around the knee, which is post-traumatic, and it is some sort of the angular deformity, and multiple deformities here, especially in this scenario. You can see there's a flexion contracture of the knee and there is an extension. So complex deformity in 2 planes equally. One is flexion, other is extension. So what are the common causes? When we're talking about the causes, can be the trauma, maybe malignance, infections, epiphyseal arrest, metabolic bone disorders, especially after rickets, osteoarthritis, rheumatoid arthritis, Blount's disease. These are the common problems which leads to the deformities. And what are the treatment options? These are the general treatment options, especially in children, and non-operative treatments if your deformities are lesser type, and operative treatment, which consists of the osteotomy and fixation with plates, wires, nails, and with fixation with the ring fixator, which can be the TSF or classical hybrid type of the laser ring fixator, or even monorail. So when we are talking about the correction of the deformity, we have to follow the principles of correction. And when we are talking about the principle of correction, we have to follow the alignment. So we have to draw the mechanical axis, and when they are not falling in the normal, so then we have to apply the malalignment test, that what is the source of the deformity. When there is a mechanical axis deviation, means your mechanical axis not coming in the center of all joints, hip, knee and ankle, so it means it is deviated and there is a deformity, which may be varus, valgus, procurvatum or recurvatum. And we have to apply the malalignment test to see the source of deformity. So then we have to draw the individual axis of the each bone, mechanical axis, and we have to draw the joint orientation lines. And then we have to assess the normal value for whole limb. Then we have to decide what is the source of deformity, and then we have to plan accordingly where is the exact source and what sort of osteotomy and what sort of implant should be used. So if we're talking about the knee, you can see, we have to see from front and also from the side, and we have to see the joint orientation with normal mechanical axis, and then we have to decide what is the point of angulation. In this case, when we are talking about the deformity, so it is the intersection of the lines, mechanical lines or anatomical lines which are intersecting and making the cora. So this is the center point where the angulation is occurring. That is cora. And the lines, which is the alpha angles and beta angles, these are the lines which are dividing our angular deformity, especially if it is in one plane, into beta angle and alpha angle. And a line which is transverse line, which is dividing the angulation into equal halves, it is called transverse bisector line. So in this case, it is here is a cora. इसकी लाइट नहीं जल रही, हाँ भाई, पॉइंटर देख ले. So this is the transverse bisector line, and the red line, it is the axis of correction. कहाँ से होगी? Yes, thank you. So this is the proximal tibial line or the mechanical axis. This is the distal fragment. The point where they are intersecting, it is the cora. And this is angulation. This is making angulation, which is valgus angulation here in the tibia. And this is the beta angle, which is transverse bisector line, which is dividing this angulation into two equal halves. And this is the transverse bisector line. And here is the cora. And this axis, on this line, all the correction, if it is made at this point, it is going to correct your deformity exactly. Next. Next. इससे आपकी स्लाइड नहीं मिल रही. So this was about the transverse bisector line, and from the, we have to judge the plane of deformity, whether it is a uniplanar deformity, and it should be seen in a frontal plane and sagittal plane, and biplanar deformity, oblique plane deformity, and when there are multiple deformities in a single bone, it is called multi-apical deformities, when you have more than one cora in a limb which are going to form a deformity, so it is called multi-apical. So means it has a multiple source of deformity or multiple axes or apices where the deformity is there. So there are certain rules of osteotomy to correct the deformity. There are three rules. One is osteotomy rule 1. When the osteotomy is done or passing through the axis of correction of angulation at any point on the cora, it is called rule 1. Here you can see this is the cora and this is our transverse bisector line, and when the osteotomy is done here and our axis of correction is also at the apex of the deformity, so when we are placing our axis of correction here, it is going to correct the deformity, and if we are placing on the convex side of the deformity, our axis of correction is placed at the convex side, it's going to produce the open way. If it's being placed at the center, it is going to produce half closed, half open, and if it is placed on the other side, it is going to produce the closing wedge osteotomy. So when you are placing the osteotomy and at the site of cora and your axis of correction is there, it is going to correct the deformity exactly. So this is type rule 1. Osteotomy rule 2 is when the axis of correction is through the cora, but the osteotomy is done at a different level due to certain reason. So what it is going to do, the axis will be corrected normally, but there will be little translation at the point of the deformity, because the osteotomy is done at the other side and the axis of correction and the cora is at other side. And this is osteotomy rule 3. When the osteotomy and axis of correction are at the level above or below the cora, or proximal or distal to the axis, that the bone will not only be corrected, but it will be translated. So that is the osteotomy rule 3. So now we are coming to this was all basis of the correction, that we have to see the mechanical axes Then we have to see the source of the deformity. Then we have to apply the rule of osteotomy. And then we have to see, especially in a multiplanar deformity. Here you can see this is the anatomical axis, especially when we are talking about the tibia. Proximal joint, proximal segment, this is the mechanical axis, proximal and distal. This is the intersection making the cora. And here, if we are going to have a line here, so it is making the cora here and also here. So this bone is deviated and making the two coras. Now how can we do correction? If we are drawing the mechanical axis from proximal side, our lateral distal femoral angle is okay, it is 87, and our medial proximal tibial is also 87, it means okay. So this is going down, and from distal segment, if we are going to have a distal segmental line which is anatomical, so it is crossing here and making cora here. So if the osteotomy is done here, our mechanical axis is going to be corrected with this single osteotomy. And if we are going to correct tibia exactly, we can do two osteotomies for correction of our medial proximal tibial angle and also distal when we are going to have a osteotomy in the center. See like this. This is making cora here and cora here. In a femur, when you have oblique deformity, full varus, and source is in femur and also tibia. So we have to have a mechanical axis proximal femur, distal tibia, and the in-between segment of the proximal tibia and distal femur. This is the mechanical axis of proximal femur, mechanical axis of the proximal tibia and femur, the intersecting line, and this is the bisector. So this is the cora here in the femur, and also this is the cora in the tibia. So when the osteotomy is done here, and here it is going to correct the deformity, exactly like this. Like this. And this is the X-ray. You can see same patient having the oblique deformity, which is corrected with multiple osteotomies and correcting deformities like this, and putting the nail or some other device for correction after osteotomy. Another case, mechanical axis deviation producing varus deformity. Proximal tibial line, distal tibial line. Our medial proximal tibial angle is okay. And we have two sources. One is here, where the two lines are crossing each other, and also we have deformity distally. So this is the correction. You can see the correction at the mid part of the tibia and also distal for making the correction around the ankle. So this was all about the different deformities in a multiple axes. So now we are going to have a few cases of the multiple apical deformities. Here you can see a young adult, 20 years old, having an angular deformity which looks to be a post-traumatic, and you can see an angular deformity clinically from, and this is the X-ray. So following rules of correction, applied a laser ring fixator. Here you can see in the axis of proximal segment, and our apex is here like this. So our hinges and the motor for correction of the deformity. gradual correction, and it is following osteotomy rule 2 because the deformity was exactly proximal and osteotomy was done distally because of the scars. So you can see the alignment is now okay, and this is after removal. The mechanical axis is fully corrected and in both planes. And clinically the deformities are okay, and knee range of movement is almost fine. Another young boy with epiphyseal arrest and having a oblique deformity, application of frame, osteotomy, and gradual correction of the deformity. And you can see the correction of the deformity, both mechanical and anatomical. This is the complex deformity. You can see the flexion at the knee, and also there's a non-union with segmental loss. So extension deformity at the distal fragment with bone loss, and flexion at the proximal segment with a small knee segment. So this is the application of frame and correction of the deformity. You can see the joint is relocated and the deformity is fully corrected with the bone transport retrograde to achieve the union. Alignment is now achieved. Flexion contracture and also extension contracture, both you can see clinically here. So with this, I would like to conclude that deformity correction following principle of correction with Elizarov ring fixator is a viable option for gradual correction, but it needs a comprehensive preoperative assessment and post-operative management. It is important to identify and treat the correct deformity and not create deformity in effort to treating a deformity. An isolated deformity in one bone should never be treated by correcting osteotomy of another normal bone. So thank you very much. Any question if you have? No question?
So Dr. Zamir, excellent talk. I know you have a great experience in this type of work. As you know, this hall, we have a lot of junior residents also. What would be your message to junior residents when they see this type of complex deformity, for how to get on this, although they have done fellowship but they don't have experience, how to start managing these deformities, especially for juniors?
Especially for our youngsters, they have to avoid the complex in initial phase. They have to understand the mechanics and also they have to follow the principles. But before addressing the very complex issues, they have to do these simple apical deformities which are angular, and once they are going to have a good experience of doing these, then they have to address the complex deformities. That will be my message for our youngsters.
One of the ways that Dr. Haroon actually teaches, I don't, is on paper tracings.
Yes.
So we trace the deformity on paper, make osteotomies and make corrections. That becomes easier for residents to understand such complex. But because your and my level of experience, we don't do that. So
Yes.
that may be one method to kind of understand the correction level.
Of course. Thank you. Thank you, Ali.
Thank you so much for such an informative talk. Now we'll move on to free papers. First one is by Dr. Muhammad Inam. Segment transport with Elizarov that causes spontaneous healing of gap at docking site in long bones, a case series and review of literature. Dr. Muhammad Inam.
Thank you. मैं अपनी एक 3 केसेस का सीरीज प्रेजेंट करना चाहता हूँ. I will present my case series of 3 cases that has a unique healing power. Yes, my name is Dr. Mohammad Inam and I am working as a associate professor in Lady Reading Hospital, Peshawar. Next, please. Theoretically, the gap may not heal without intervention. Like in these cases, the gap has healed without any intervention. That is my case presentation. So, there are different work has been done for gap non-union, that is stud graft, bone chips, bone morphogenetic protein, different type of thing has been done. But this thing which I have to present, this is unique. Case 1 is that there was an 18 years old road traffic accident boy. He had a road traffic accident. He had a fracture of the femur. Initially, that was open and was treated with external fixator, AO external fixator. That became infected. At that time, the patient was very serious. He has pulmonary embolism. He was taken into the ICU. When the patient was stable, he was again shifted to the unit and the external fixator was removed. The debridement was done. Infection was subsided, then intramedullary nail was given. After intramedullary nail, there was no healing. And after a multiple surgery, there was no healing, so we decided to do the Elazarov. These are not quality X-rays. But if you can see, there is a gap in the initial X-ray, and this was intramedullary nail, which was given with the plate fixation. We removed all these things, and we did Elazarov with segment transport. In X-ray 1, if you see that there is a gap, but in X-ray 2, the gap is filling by itself. When we start segment transport, the patient has severe pain. So we did X-ray and we stopped the segment transport. And we saw the callus. Then we stopped the transport and we were waiting for maturation of the gap. Then there was maturation of the gap with the callus. In case 2, this was a 60 years old male. He has sustained open fracture of the tibia, Gustilo type 3. Initially, he was treated in another hospital with AO external fixator. But there was, in tibia, there was AO external fixator, and in the fibula, there was only K-wire. What we did, we removed all these things. There was infection. We treated the infection, but it was not healed. What we did, we removed the bone segment. This was about 9 centimeter segment that has been removed, that was dead, and we did Elazarov with segment, for segment transport. If you can see, the initial AO external fixator, K-wire and screws, and infection of the skin and the segment as well. When we started segment, again there was pain after 3 months of the segment transport. When we did the X-ray, so the patient had distally at the gap side, there was a little bit callous. So we were afraid that there may be something infection, but there was no infective markers. So we stopped the segment transport and waited till the maturation of the gap as well as the segment side. In case 3, again there was a 50-year-old male that was smoker. He has a rotafac accident and femur fracture. He has been treated initially with the plate and screws, then that was broken, that was removed, intramedullary nail was put in, that became infected, a leg bone graft, and a lot of surgery has been done, but finally he came to us and we did Elazarov with segment transport with removal of the dead bone. The initial X-ray, if you can see, there was a gap. And at the last X-ray, if you can see that there is a callus that has been formed in the gap. So when we review the literature, there was only 32 cases of long bone that has been spontaneously healed in the gap without any intervention. But this healing was only and only done especially more in mandible. In the long bone, only 32 cases, and more was only in the mandible. The mandible was tremendously healing properties, but in the long bone there was only 32 cases. Still there is this one thing that why that has been healed. Some people say that there may be some periosteum that has been left there. But in second case, if you can see, we have removed each and everything. Still there is healing. If these 2 cases has periosteum, remnant of periosteum, that is okay, we can accept. But in this second case, there is no periosteum and still there is healing. So these were unique cases which I want to share to you, and I also want to know about the healing properties, that what are the factors that heal such bone without any intervention. Initially, multiple surgery has been done. At the segment transport site, there was no bone graft given. At the segment transport site, that was empty, totally empty. But still there was callus has been formed. Yes, by active exercises.
The contracture and weight bearing, what is your weight bearing policy? And you just stop the 3 cases, or you are doing further cases?
If you do Elazarov, you will move the patient on day first. He will do exercises. He will do activities like normal life.
Thank you very much, Dr. Saab. It is indeed very impressive. And but the science has to believe in the miracles, and the religious scholars, they say Almighty Allah, He does so in such cases. My question is that you have not shown the ultimate outcome, the functional outcome of the patients, whether that was stable or it was there certain support was needed over. And not to having the mic, one thing, compression, distraction, osteosynthesis, the principles of Elazarov, these are very much obvious. And that may be under certain stress forces which have been formed over there. I would love to see if the end result is over there, which has been the bone formation, then certainly I feel that science has to think about it. Thank you.
all the 3 patients healed without any bones segment transport. Initially, there was a segment transport in one case of 2 centimeter. In the second case, there was segment transport of 5 centimeter, and 6 centimeter gap was healed without any intervention. And in the third case, there was only 2 centimeter segment transport, and the 4 centimeter gap was healed without any intervention. All the 3 cases healed. Yes. Yes, if you can see, sir, if you can see the first and second case, we have removed all the implants and the patient was okay. He was mobile without any crutches, without any stick. The first and the second one. The third one is the last case, which has the last follow-up, in which we have not removed the laser of his yet. The first and the second. Yes, initially, yeah. Initially, when he came, he was treated in another hospital. He was in ICU, admitted in ICU due to pulmonary embolism. We don't know what has been given. We have not given anything. Yes. Yes. Yes.
Thank you, Dr. Nam, for sharing your cases. I would say that the possible answer for these is, one is the stability and mobilization, and other is that infected material you have removed from the site and you have mobilized the patient. So that could be the possible reason that in non-union, the main factor is instability. So one is the stabilization, because you have provided them a good stabilization, it's a ring fixator, and you have to mobilize. And you have removed the hardware in first case, which was nail and plate inside, which was infected. So once it is infected, the environment is clean, and you have provided stability and mobilization. That could be the possible reason for the union process. Thank you.
Thank you. I'm Dr. Wasif here from Sheikh Zayed Hospital. I think we should believe in science. If you see the Elizarov, it is basically the compression distraction, and somehow it was the distraction and the distraction of the fibrous tissue which has given some of the callus and it healed, because it was a stable situation. But it never happens in all the cases, you see. It happens in very few. And why are you saying that you didn't intervene? Actually, you intervened in all the 3 cases. You had the segment transport and you were not able to actually dock, because before that you saw the callus and you just stopped there. So intervention was already there. And thirdly, I will also second with the Professor Ashraf Nizami that we couldn't see the final healing. I mean, was the patient mobilized? Was they were walking without any support or any something like braces or something? Or in the third case, we didn't see the full healing. It was just a callus formation which we saw. We believe in you, okay, fine, but for the sake of, more confidence, if you can say.
आपने बिल्कुल ठीक कहा. मेरे पास एक पेशेंट की भी वीडियो इसलिए नहीं है कि कुछ पेशेंट जो है ना हमें अलाउ नहीं करते. ये जो पिक्चर्स है ये हॉस्पिटल की पिक्चर्स है जो मैंने लिए हैं, तो इस वजह से. और जो मेरे जो कलीग्स है जो LRH में काम करते हैं उनको पता होगा कि जो हमारा सिस्टम है वो इतना सख्त है कि मैं जो काम करता हूँ वो मुझे भी पता नहीं होता कोई क्या होता है. तो इस वजह से अब मेरी क्लिनिक की केसेस है, मैं आप लोग को बताऊंगा कि क्या है. इंशाल्लाह मेरे 2 पेपर और भी है. लेकिन ये जो केसेस है मैं इसलिए आप लोगों से शेयर करना चाहता था कि मैंने लिटरेचर में देखा है कोई भी इसका आंसर नहीं है कि ये जो है ना क्यों है कि आप सॉफ्ट टिश्यू को जो है ना स्लोली अगर कंप्रेस करते हो, डिस्ट्रैक्ट करते हो तो वो तो ठीक है, वो बोन में कन्वर्ट हो जाते हैं. ठीक है, लेकिन इन केसेस में अगर ये 32 केसेस स्पॉन्टेनियसली हील हुए हैं लॉन्ग बोन में, उसमें भी कोई जो है ना उन्होंने नहीं लिखा कि ये किस वजह से हुए हैं.
Thank you, Dr. Inam. In interest of time, we won't take any further questions. Now I'll request Dr. Mohsin Javed to present his free paper. Please stick to your time.
Assalamu alaikum. I am Dr. Mohammad Mohsin Javed, a resident orthopedic surgery from Holy Family Hospital, Rawalpindi Medical University. Today I would share our experience on the congenital pseudoarthrosis tibia, which is treated with the laser fixator. Firstly, I would appreciate, and as a lot of discussion is being done on the laser fixator, so a little more that I can add with my experience. This is, the study was originally done by Professor Dr. Zubair Javed, who is our head of department. I have no conflict of interest. So congenital pseudoarthrosis tibia, it is present in 1 in 250,000 live births. It is closely associated with neurofibromatosis, but neurofibromatosis may not be its cause. It commonly involves the distal half of the tibia, and variable forms of fibrous dysplasias are associated. The poor cause of healing in pseudoarthrosis tibia is unknown. However, literature states a few causes, which are the hematomatous thickening of the fibrous tissue, limited and imbalance of the vascular potential, thickening of the adherent periosteum, and osteolytic fibromatosis. In our theory is that the defect in the healing and the callus formation is primarily because of there is an imbalance between the osteoclastic activity and the osteoblastic activity, which is leading for a poor healing. So atrophic type of pseudoarthrosis tibia is much more challenging. It involves the excision of the fibrous hematoma, removing of the sclerotic tapering bone ends to achieve sufficient cross-sectional area in order to drop the trabecular bone, and to address axial malalignment and ankle stabilization. Initial management, yes, of course, it includes resection of the entire pseudoarthrosis and surrounding hematomatous tissue. Osseous union is difficult to achieve. It has a success rate of only 30 to 56%, and there is incidence of refracture in 50% of the cases. Yes, even in our case, there were revision surgeries which were done. I will tell you later. So the primary thing is to address the limb length discrepancy, which further increases the time for healing. The revision surgeries are frustrating for surgeon, as well as it adds to the agony of the patient. So if we look at the natural history or the cause, which is neither predictable nor alterable with surgical and medical treatment, the primary and basic aim is to achieve bony union at pseudoarthrosis, restore the leg length discrepancies, prevention of the malalignment, and address ankle foot problem, if I'm not. Yes, so method employed are intramedullary nailing, free fibular graft, vascularized or non-vascularized depending upon the size of the defect, a laser-off technique, and sometimes a combination of all is used to address the problem. Why did we choose a laser-off fixator? Because the primary aim was to achieve limb lengthening, compression at the fracture site after generous excision of the pathological bone and soft tissue, to address the valgus foot and ankle deformities with the same apparatus, as well as the experience at the Rawalpindi Medical University, where the laser-off fixator was boosted after the earthquake of 2005, which led us to study and use laser-off fixators in much more cases. This was a study, as I said, it was done at Rawalpindi Medical University. The study was done over the period of 10 years with prospective cross-section study, and the pseudoarthrosis tibia were divided by the Boyd's classification. Children below 5 years, only 3 rings were applied, and the middle ring was used for distraction purposes. 1 ring in lower fragment of tibia may cause anterior angulation of the distalmost fragment, and to address the plantar flexion at the foot, the resection of sclerotic ends of pseudoarthrosis was done generously. Hematomatous tissue and tapering ends of the bone were excised till the good bleeding margin of the bone as well as the 70% of the shaft diameter was gained to increase the contact surface of the 2 bone ends. An attempt was made to achieve compression at the fracture site to avoiding a gap more than 4 centimeters, but later on the gap was reduced to 3 centimeters as there was a complication in one of the cases that there was a kink of the vascularity, and we had to address this issue peroperatively. Osteotomy was done at the proximal tibia. Distraction in the younger children was started at the 8th day and later, and depending upon the age, to the 10th to 12th day. How we were different from other principles that we had a distraction of 0.5 centimeter a day. How did we check that? Because we had an increment distraction in a day. That means every 8 hourly patient was going through a distraction phase, not single distraction per day. That is, we believe, made us different from the other practices commonly done. For poor bone healing, the increment was further decreased to 0.5 millimeter per day. For accurate approximation of the middle and distal fragment, K-wire was used from heel in order to railroad the middle fragment. So these are the results of our study. 16 cases were included. Out of them, 6 were females and 10 were male. The age which ranged from 2 till 18 years, and 10 patients were classified into Boyd 1 and 6 into Boyd 2. The evidence of neurofibromatosis was seen in 9% of the cases out of 16, and limb length discrepancies range from 2 till 10, and revision surgeries were required in only 6 cases. Yes, we did have complications. The complications which mostly dealt were LLD, malalignment, and delayed consolidations. Bone grafting was required in only 3 patients. 1 patient at the age who was of 7 years had one complication, that the affected limb was significantly or maybe larger than the normal limb, which was 1.5 centimeter. These are the few cases which were done, which shows pre and post operatively. This is the case of an 18-year-old female patient. This is the case of 7-year-old female patient. Later on, she was giving knee ankle brace for walking purposes in order to achieve a good bone stock. This is the case of a 7-year-old female child. This is the case of another 7-year-old male child who probably kind of lost to follow-up as he was unfortunately a Afghan refugee and he had to move back to his country because of the visa purposes. Yes, this was another complication which we saw, that there was unexplained resorption. Maybe the seniors over here in jury who can help us understand why was there a resorption of the proximal tibia and at the site of osteotomy and distraction, which resulted in formation of the proximal pseudoarthrosis. This was a case of another 10-year-old male child and then 17-year-old female child, which has a gross deformed tibia. So I'll conclude it that it is still poorly understood disease. Perhaps the primary disease perhaps it's primarily a periosteal disease with decreased osteoblastic activity and increased osteoclastic activity, and results are yet unpredictable. Thank you so much.
Next, I'll invite Dr. Rizwanullah to present his free paper.
Assalamu alaikum. My name is Dr. Rizwanullah. I'm a postgraduate orthopedic resident, Khyber Teaching Hospital, Peshawar. Today my topic is limb salvage with Elizaro technique. next. The prime aim of limb salvage is to bring back or preserve the function. The selection of the salvaged limb should be individualized for each patient, taking into analysis not only the extremity wound, but also the corresponding injury, age, and socioeconomic status of the patient. Aggressive debridement and skeletal stabilization, followed by early reconstruction, are the modern standard of practice and give better result than the more traditional approach of repeated debridement and delayed flap cover. Purpose of the study is to evaluate the limb salvage by Lazaro technique in trauma and infection. The study was brought between the 2017 and 2021. A record of 18 patients with the trauma and infection and treated with a Lazaro technique method were retrospectively reviewed. Aggressive debridement and the removal of the dead bone followed by osteotomy and segmental transport with the bone loss. And for infection control, multiple times antibiotic beads and antibiotic coated nail were placed. The total 18 patients, the result showed among the 18 patients, 14 were male and 4 were female patients with the average age of 35 years. And patients were followed for 4 years. Bony union and infection eradication was achieved in almost all patients. A Lazaro method is a good salvage operation for trauma and infection, and it is a preferred to prosthesis of the, if the limb is viable, adequately innervated, and the patient is mentally and financially committed to save the limb. This is one case which was treated in our unit. A young male patient was referred to us with a history of RTA and was advised above knee amputation. This is pre-op X-ray, and then we treated with a Lazaro technique. This is the immediate post-op X-ray and the post-op picture. This is the next follow-up X-ray. Then, due to cumbersome of the patient again requested us to remove this because it was difficult for him to take care. Then there was a discharge from the wound, for which we removed the Lazaro and we put antibiotic beads. This was the tibia X-ray. This is the follow-up X-rays and the patient picture. For the femur fracture, we then, after eradication of the infection, we fixed the fracture with the plate. And for the tibia, we put the Lazaro frame. This is the video of the patient. Kindly play the videos. Next. This is case 2. A young patient was referred from one remote area with a history of RTA and degloving injury of the right forearm, the dominant side. Initially, we did DD debridement in the emergency and then followed by the Lazaro fixation in the next main list. This is a 4-month follow-up X-ray, the 4-month follow-up patient's picture. And this is the follow-up after removal of the Lazaro. In between, there was a discharge from the wound, and then for that eradication, we put antibiotic beads. This is the last X-ray. Unfortunately, we don't have the last X-ray for uploading. Thank you. Thank you.
Now this is the last talk of this session. Dr. Safirullah will present paper on reconstruction of unstable hip in pediatric Lazaro.
Assalamu alaikum. My name is Dr. Safirullah. I am a resident at Haber Teaching Hospital, Peshawar, and I am representing my paper on the behalf of my supervisor, Professor Dr. Muhammad Shoaib Khan. Next. My topic is reconstruction of unstable hip in pediatrics with Elizarov techniques. In pediatric population, hip can be damaged by multiple causes like septic hip, sequelae, neglected developmental dysplasia of hip, neglected femoral neck fracture, and tuberculosis. The Elizarov techniques provide a stable hip by elevating Trendelenburg lurch, equalize limb length inequality by distal femoral lengthen realignment osteotomy. Material method and methods: 10 patients with unstable hip due to multiple causes were treated with Elizarov proximal pelvic osteotomy and distal lengthening realignment osteotomy. In study group, 6 were female and 4 were male, and age ranges were from 10 years to 16 years. Average limb length inequality was 4.8 centimeter. Average was 3 to 7.5 centimeter. Pre-operative and post-operative range of motion and Harris hip score was collected and data analyzed by students per test. A p-value of less than 0.05 was taken to be statistically significant. Results: in all patients, Harris hip score was improved at last follow-up. Pre-op mean Harris hip score was 51.35, range from 30 to 75, which was improved to 85.40. Range is 71 to 85. In all patients, at final follow-up, which was statistically significant, p-value was less than 0.05. Average achieved length was 4.4 centimeter, range 3 to 7 centimeter. The mean Elizarov fixation time was 7.4 months. Conclusion: pelvic support osteotomy Elizarov is the best salvage surgical procedure for unstable hip due to various etiologies and pediatrics population where other procedures are inappropriate and allow this age group excellent functional outcome. However, for best outcome, it needs follow-up and expertise. These are cases: one girl, 14 years old, with septic hip sequelae. She was PSO was done, and this was X-ray after removal of frame, and this is her video after last follow-up. Kindly play the video. This was another patient in which PSO has been done, and Trendelenburg was negative, and he can sit and squat. This was another case with avian hip avian. PSO was done, and LLD and other parameters were corrected. Now he can walk, and this is video. You may play this video. Kindly play the video. Nowadays, my mentor has changed the techniques, and nowadays he is doing PSO with plates. If you have any question, my supervisor is over here. He will answer your question. Thank you.
Thank you so much. This concludes our session number 1. Since we are quite short of time, we'll skip comments by the panelists and we'll move on to session number 2. I request Dr. Abdur Rahman to kindly moderate the session.
Assalamu alaikum warahmatullahi wabarakatuh. Alhamdulillah wa salatu wa salam ala Rasulullah sallallahu alayhi wa sallam. It is the beginning of our second session on the Elizarov. I will invite my esteemed panelists to come forward and take your respective seats. Dr. Harun Rashid, Professor Shoaib Khan, Professor Zamir Sumro, and Dr. Ahmed Awad. Please, sir, take your seats. And I will start from my first speaker, Dr. Muhammad Inam. Dr. Muhammad Inam for his free paper presentation on comparison of pin site infection rate between Chan's screw and K-wires in Elizarov external fixator for tibial fractures. Dr. Inam.
Assalamu alaikum. This paper has been published recently, and those who are doing Elizarov, they know very well that pins are more prone to infection than K-wires. So we did an randomized controlled trial study to compare the pin site infection between shunt pins and K-wires. Randomized controlled ट्रायल स्टडी है और 6 महीनों की है. 66 पेशेंट नॉन प्रोबेबिलिटी कंसेक्टिव सैम्पलिंग टेक्निक. एज पेशेंट की ये थी, बोथ जेंडर, आइसोलेटेड फ्रैक्चर ऑफ द टिबिया. इसमें हमने 2 ग्रुप लिए. जो सैम्पलिंग टेक्निक था वो कंप्यूटर जनरेटेड रैंडम सीक्वेंस नंबर हमने दिए थे. ग्रुप ए था, ग्रुप बी था. ग्रुप ए में जो है ना के वायर एंड शन पेन्स, और ग्रुप बी में सिर्फ के वायर्स थे. तो हमने इसको जो इन्फेक्शन साइट है उसको जो क्लासिफाई करने का तरीका है, एक मूरे एंड डाल पेन साइट क्लासिफिकेशन है, वो यूज़ किया है, जो उन्होंने 6 ग्रेड्स पे डिवाइड किया है. स्टडीज़ जो एज ग्रुप थी उसमें सैंपल में 83 मेल, 83 ग्रुप ए में थी, 83 ग्रुप बी में थी. टोटल जो पेशेंट थे वो 166 थे और मीन एज उनका 35 इयर्स था. जेंडर ग्रुप ए में मेल 55 थे और फीमेल 28 थे. ग्रुप बी में 58 मेल थे और बी में जो है वो 25 थे. Mechanism, mean duration of injury in group A, there was in mean group, this is days. In group A, there was 15 patient that has infection and 68 patient has no infection. While in group B, there was only 6 patient that has infection and 77 has no infection. If we stratify this data with both age groups, so 20 to 40 years age group, in group A, there was infection 28% pin site infection, while 33% has no infection. While in group B, there was 2%, only 2 patient has infection and 33 patient has no infection. So age above 41 up to 60, there was 5 patient that has pin site infection in group A and 36 has no infection. While in group B, there was only 4 patient has infection and 44% has no infection. If we stratify the data with the gender, so male in group A has pin site infection in 8 in group A, and male in group B has only 7% infection. If we stratify duration of injury with the pin site infection, so less than 7 days of injury, that has only 2% of infection in group A, and in B group 2 patient has infection. Likewise, more than 7 days of injury, the total infection was 13 in 25% in 13 patient and 7.4% in 4 patient of pin site. So conclusion, using hybrid Elizarov can use pin site infection. That's why the followers of the Russian Elizarov technique do not use pin. Our study concludes that the frequency of pin site infection is significantly less in Elizarov fixator using K-wire as compared to Elizarov fixator using shunt pins. Thank you.
Assalamu alaikum. I will again invite Dr. Inam for his second paper, deformity correction of lower extremities by application of Elizarov external friction.
डिफॉर्मिटी करेक्शन बहुत तरीक़ों से की जाती है, लेकिन ये जो सीरीज़ है हमने डिफॉर्मिटी करेक्शन जो की है सिर्फ परक्यूटेनस ऑस्टियोटमी से हमने जो है ना ये डिफॉर्मिटी करेक्शन की है। लेस देन 2 सेंटीमीटर इंसिजन से कार्टिकाटमी की है और उस वजह से जितना भी हमारा सीरीज़ है इसमें इन्फेक्शन बहुत ज़्यादा कम है। Objective of this study is to evaluate the result of osteotomy and application of Elizarov of lower limb deformities. केस सीरीज स्टडी है, 23 पेशेंट का है, ईदर सेक्स। ये स्टडी बहुत पहले हमने शुरू की थी, 2016 में शुरू की, 2021 में ख़त्म हुई। स्कैनोग्राम बहुत लोअर लिम्ब का स्कैनोग्राम बहुत ज़्यादा ज़रूरी है, तब आप डिफॉर्मिटी के मैग्नीट्यूड को आप मेजर ही नहीं कर सकते जब आपके पास स्कैनोग्राम नहीं है। आम एक्सरे से जो है ना ये होता ही नहीं है। और मज़े की बात है कि स्कैनोग्राम पेशावर में सिर्फ एक ही जगह पे है, हमारे पास नहीं है वैसे। अच्छा, इन स्टडी में जो मेल पेशेंट थे वो 9 थे और फीमेल 14 थे। जो मीन एज था उनका 19 था और जो मीडियन मूड और स्टैंडर्ड डिविएशन 7 था, मिनिमम एज 10 था और मैक्सिमम एज 40 था। जो दोनों साइड इन्वॉल्व थे डिफॉर्मिटी के लोअर लिम्ब के, तो उसमें 6 पेशेंट थे, लेफ्ट साइड 8 पेशेंट और राइट साइड जो है ना 9 पेशेंट। Ankle deformity, 4 patient, femur, 4 patient, knee, 8 patient, tibia, isolated tibia, 7 patient. Surgery, 7 patient में double osteotomy हुई है और 16 patient में single osteotomy हुई है. Correction is not perfect but acceptable. जब ये हमने डिफॉर्मिटी को करेक्ट किया तो 4 ऐसे पेशेंट थे कि उसमें जो है ना परफेक्ट नहीं थे, और लेकिन ये था कि एक्सेप्टेबल था रिडक्शन. 10 पेशेंट में कोई कॉम्प्लिकेशन नहीं थी, लेकिन इसके बाद जो पेशेंट है 7 में कॉम्प्लिकेशंस थी. क्या थी? पिन लूजनिंग थी, पिन ट्रैक इन्फेक्शन था और रिस्ट्रिक्टेड रेंज ऑफ मूवमेंट थी. अच्छा, ये एक नेग्लेक्टेड सीटीवी है, बल्कि आप रेजिस्टेंट सीटीवी है. इसकी ऑलरेडी जो है ना पीपी कास्ट अपने बचपन में हुई है, मल्टीपल टाइम्स पीपी कास्ट इसकी हुई है. 3 साल तक मुसलसल हर हफ्ते इसकी पीपी कास्ट हुई है. तो हमने ये 13 इयर्स की ओल्ड बच्ची है, इलेजरोफ किया हमने, और इसका फाइनल जो है ये है. ये 22 इयर्स की ओल्ड लेडी है, इलेजरोफ हमने किया, सिंगल ऑस्टियोटमी. ये जो है ना इसकी लास्ट फाइनल है. और ये एक टिबिया की ऑस्टियोटमी की है. ये रोटेशनल, जिस तरह सर ने कहा था कि ये जो है ना रोटेशनल डिफॉर्मिटी थी, उसके लिए जो है ना हमने ये किया है, और इससे इलेजरोफ हटा के ये जो है ना इसकी फाइनल शक्ल है. तो जो इलेजरोफ है, कंक्लूजन क्या है कि इलेजरोफ एक्सटर्नल फिक्सेटर इज बेस्ट फॉर डिफॉर्मिटी करेक्शन इन ऑल डायमेंशन and direction if the patient and the attendants are compliant otherwise. Physiotherapy and exercise can prevent many complications and make it success. Thanks.
Thank you for nice presentation, Dr. Inam. For our next presenter, Dr. Mohsin Javed Zubair. Correction of rigid CTEV in maturity foot by Elizarov ring external fixator. Please, Dr. Javed.
Thank you, sir. I will brief myself. I am Mohammad Mohsin Javed, resident of Holy Family Hospital, Rawalpindi Medical University. This talk is about correction of the rigid congenital talipes equinovarus in mature and near mature foot by Elizarov with fixator. As mentioned by Dr. Inam that they have corrected club foot which were resistant. This is the published study. I have no conflict of interest. So to begin with, I'll present with a case of 40-year-old male patient who presented to our OPD. He was a resident of far-flung areas of Kashmir, so he had limited resources for health care, and he presented with limited and difficulty upon walking. And this is the pictures of neglected bilateral clubfoot deformities. It is I believe that it is yet one of the commonest deformities in our region, because people are still who live from the far-flung areas, from the urban areas, and they have limited access to the healthcare facilities. So the clubfoot deformities are yet being skipped and not addressed to the fullest. The deformity is worsening as the age progresses. The foot remains rigidly supinated with attitude of forefoot in adduction, heel in varus position and equinus position. Triple orthodesis, our principal author believe that triple orthodesis makes the already smaller appearing foot much more shorter. Why choose Elizarov? The correction of the rigid forefoot with Elizarov is very challenging. It can correct all deformities, even in adulthood and adolescent age group, which avoids the extensive incisions, multiple bony extensive osteotomies, and wedge excisions, and complications like foot infections if managed with cast and neuromuscular compromise. Our sequence of correction was that we addressed supination of the foot, varus at heel and forefoot adduction, which was followed by the cavus correction, and the equinus at the hind foot was addressed lastly. The acceptability relates to the cosmetic outcome and the comfort of patient upon walk. The study was done at Rawalpindi Medical University, and 16 feet, bilateral or unilateral, were selected in our study. Mature or near maturity foot were selected. And cases where previous surgeries were done, they were not included in our study. And bilateral cases were operated in 2 stages. So we developed a scoring system in order to address what we are doing and how it is resulting in the functional outcome. So we measured the severity of deformity, acceptability of the frame and the apparatus by the patients, frame tolerance, and comfort upon weight bearing was measured. This was very easily employed even in the busiest of our clinic, the scoring system. Range of motion was excluded in our study as we had different parameters to address. So the aim was to find correction of the rigid foot with the Lazarov fixator and its acceptability. So design, I would like to tell and show emphasis that it was a 2-component of the frame. One was a distal tibia and the other was on the foot, which was implied with a C-shaped loop. The distal ring has sufficient lever arm distance for the rods and hinges to correct the varus and equinus at the heel. The hind foot was used with a multi-hole carbon fiber U-ring and overlap C-ring in case if the foot deformity or the foot size is bigger. 2 to 3 KYs of 1.8 millimeter were passed at the heel parallel to the sole, directed medial to lateral. Shank screws were passed in order to stabilize the heel construct. The KYs of, then again 2 KYs of 1.5 or 1.8 millimeter were passed as metatarsal to mount the vertical C-ring on 4 to 5 hole plate. 2 rods were connected anteriorly from distal ring to distal foot ring to address the mid-foot deformities. Cavus and medial arch disproportionate were addressed. These are the few pictures taken post-operatively. Excuse me. Manipulations at the foot were done pre-operatively. Post-surgery, gradual destruction of 1 or 2 components of the frame were initiated. Frame was kept for 6 weeks after full correction was achieved, and then it was replaced with below-knee synthetic cast, and full weight bearing was also allowed. The cast, this synthetic cast was repeated for every 6 weeks, twice. That means till 12 weeks if required. Patients' weight-bearing, comfortability, and acceptability were noted. These are the results. In a total of 10 patients, 8 were females and 2 were female. The age range was 8 to 40 years. I have pictures of 40-year-old patient I'll show next. So the age range is 32 years, mean of 17, and the foot, which were included, were so these are the pre-operative and post-operative scoring systems. So our scoring system, score 0 is least deformity, and a maximum score of 12 is the maximum deformity. So we have mean of the supination, which is 2.1, so and which is pre-operatively. So total deformity score pre-operatively mean was 10, and which reduced post-operatively to 0.3. That shows how significant the effect was with our apparatus. Mean duration of frame was 10 weeks, and it ranged from 8 to 16 weeks. Duration of POP cast mean was 10, almost 10, and it ranged from 6 to 12. AFO brace was applied after post-operatively, and it has the mean of 31 weeks, yes. So patient's satisfaction mean is 0.8 with range from 0 to 2. That means frame acceptability, the highest score is 0, that is a good score, and 3 is painful and not willing patients. So this is the case of 40-year-old male patient who presented pre-operatively. As I have told that we address 1 foot at a time. So these are the per-operative pictures. And on follow-ups, and this is the picture of the right foot. So this tells us how much correction and acceptability. So I hope we did the patient follow-ups with us for his other foot. This is the post-operative CT for And these are some of the other cases. I'll conclude that Elizarov can help achieve in correcting all rigid deformities despite age, without sacrificing extensive incision and bony corrections and avoiding complications. Ideal treatment aim for congenital talipes equinovirus is to obtain full correction and a normal-looking foot and having joint mobility at maturity of the foot. However, mobility at foot is dependent on maturity and rigidity of the foot. Thank you.
Jazakallah, Dr. Mohsin, for nice elaborative presentation. And now I will invite Dr. Zahir Khan for outcome of Schatzker type 4 tibial plateau fractures treated by Elizarov ring external fixator. Dr. Zahir.
Bismillahirrahmanirrahim. My name is Dr. Zahir Khan. I am working as an assistant professor in the Department of Orthopedic, Mardan Medical Complex. So the topic of my presentation is the outcome of Schatzker type 6 tibial plateau fracture treated by Elizarov. So the complex proximal tibia fracture, especially the tibial plateau, are one of the most challenging problems in the fracture surgery. The circular construction and tension wires of the Elizarov apparatus provides more structure support than the traditional monolateral fixator. The Elizarov apparatus usually is named after the orthopedic surgeon, Gabriel Ambroise Elizarov from Kurgan, and he pioneered this in 1950. So this is the person, and he was inspired from the shaft bow harnesses on a horse carriage, and initially the bicycles parts were used for that. So the principle of treatments are anatomical reconstruction of the articular surface, restoration of the anatomical axis, and fixation spanning the metaphyseal comminution, and further minimizing the secondary insult to the already traumatized soft tissue. So these are the instruments used for Elizarov fixation. So it needs a teamwork. So a well-qualified surgeon should perform this surgery. So these are the rings available in 80 and 240 mm. So the spaces between the skin and the ring should be at least 2 centimeters. And the general rule, two main fragments must be fixed at 2 levels, 2 rings, and 1 fragment or 1 full or 1 half ring, or 1 full ring and offset of wires. So this is the rules. So this is the space between the rings, and the application for today's practice of the Elizarov technique. It is used commonly for the limb lengthening, deformity correction, infected non-unions, treatment with joint contractures, and some of the acute fractures. So this kind of fractures can be treated with Elizarov fixator. So one should know the safe corridors in external fixator. It is prerequisite for a surgeon using external fixation system to be familiar with the safe corridor for the half pin and wire insertions. So this is the safe zone. It is divided into 6 zones. So for the shortage of time, so we will skip it. So high energy fracture of the proximal tibia, Schatzker 6, are associated with severe articular depressions, separation of both the condyles and diaphyseal comminution, and with dissociation of loss of integrity of the soft tissue envelopes. So the Elizarov technique is well suited for the management of proximal fractures of the proximal tibia when extensive comminution at the fracture site and compromise of the soft tissue is there. So Schatzker type 6 are mostly fractures mostly require surgical management with the main aim of restoration of the articular congruity and attaining anatomical reduction and stable fixation and adequate early knee motion. So this is our study. This study was conducted in Mardan Medical Complex. It is a 2-year study from 2021 to 2022. So there were only 26 patients we operated in this duration, and the 15 patients were open, and the 11 patients there was a closed comminuted fracture of the proximal tibia. So all the patients, they fracture usually caused by the motor vehicle accidents, motorcycle accident, and pedestrian patients. The post-operatively, all the patients were healed, but there were only 46.1% have a fair results, and 30.7 had a good result, and 15.3% has an excellent result, and 7.2% patients have a poor result. So these kind of patients can be presented. The soft tissue condition can be appreciated. One can appreciate this as well. So this was the fixation initially. We were done under C-arm. So this fixation was done. This is another case that has been fixed. There is olive wire has passed on either side to reduce the fragment. And so these are the different kind of X-rays that has been managed with Elizaro fixator. So in the middle, one can appreciate that the olive that has been passed to the metaphyseal part because it's a cancellous bone, so there should not be that much tension at that level. So depressed articular fragments often necessitate elevation. The failure to reduce the articular fragment often necessitate an open reduction. A small window that has been created in the tibial cortex, and with the bone elevator, that fragment can be elevated. So this is the, one of the procedure, one of the technique that is taking the fragment and maintaining the articular surface. ORF with osteosynthesis and dual plating is the most stable mechanical construction in the proximal tibia fracture, but it has some more complication as compared to the Elizaro fixation. So these are the drawbacks of this method: extensive soft tissue dissection over the subcutaneous proximal end of the tibia, excessive periosteal stripping, and devascularization of the periosteum and skin necrosis and infection. So the Elizaro technique is a safe, effective method associated with low morbidity in the fracture of the proximal tibia. So our conclusion that Elizaro external fixer is a better treatment option for the short skirt type 6 fracture, as adequate reduction, wound care, and early mobilization not only reduce the stiff knee but also leads to early fracture union. Thank you.
Jazakallah, Dr. Zahir, for recapitulating the knowledge from the basics to the advanced cases. Now I will invite my last presenter for free paper, Dr. Muhammad Ismail, role of chipping with the bone grafting in the complex non-union of long bones.
Bismillahirrahmanirrahim. I am Dr. Muhammad Ismail, a postgraduate resident of Khyber Teaching Hospital, Peshawar. Today I will talk about the role of chipping with bone grafting in the complex non-union of long bones. So the methodology of my study was conducted in the department of Khyber Teaching Hospital. The duration of my study ranged from January 2021 to January 2022. And a consecutive non-probability technique was used for this study. A total number of 103 patients were managed by this technique. All the patients were treated with an appropriate fixation technique, including revision of the implants, and were followed for at least 6 months. And in the follow-up visits, the patient's clinical markers of bone healing were evaluated along with some radiological signs of bone union. Clinically, the patients were assessed for resolution of pain with weight bearing, and there was no movement at the fracture site. And radiologically, there were signs of union on 2 or more views. The results of my study was a total number of 103 patients were included in the study. 89 patients were males and 14 were females. Age of the patients ranged from 16 to 80 years. Among them, 60 patients had femoral fracture non-union, 28 had tibial non-union, 7 had humerus, 3 had both ulna and radius, 3 had isolated radius, and while 2 had isolated ulna non-union. All the patients were treated with the non-union side chipping using an autogenous bone grafting from the iliac crust of the same patient. These patients were followed for at least 6 months. 97 patients achieved union successfully, while 6 patients failed to get union, and then they required some further interventions. While 5 patients got LLD of 2 centimeter, while 5 patients had ipsilateral knee stiffness in cases of femoral non-union. So the conclusion of this study was that this technique of bone chipping with autogenous bone grafting for the complex non-union of long bones is very easy to perform and is very encouraging procedure. I will show some pictures. So these are the, how can I make? This is the way how we are doing the procedure. Using a small acetome and low energy trauma, we are making chips after clearing the soft tissues from the bone ends, and these are some pictures you can see. This is the autogenous iliac crust bone graft taken from the iliac crust of the same patient, and then we mix it with some antibiotics just like vancomycin. And this was a case we have done recently. This was a case with DFLP, and the patient went in non-union. Luckily, the implant was stable, and we cleared the non-union side, did the chipping, as you can see here. Then we put the iliac crust bone graft along with some antibiotic. This is the immediate post-op X-ray of that patient. That patient is in our follow-up. I can show some of the cases which are previously done in our unit. This was a case of a 40 years old man, which was with also tibia fracture and ankle fracture that was managed with external fixator and cavoids in the ankle. So, and the patient was in non-union. Then we did this technique. You can see. This is a post-op after 7 months. This is the condition of the patient. This was another case which was done somewhere else. We did this. These are the just immediate post-op X-rays. This is the X-ray after 4 months. This was another case and the patient got infected island. The fracture was in non-union. We put antibiotic-coated nail and antibiotic-coated beads to eradicate the infection. Then we done this procedure. This is the post-op X-ray. You can see. This was another case with broken implant and non-union. We did the same technique. This was the immediate post-op X-ray and 2 months X-ray of the same patient. Thank you.
Jazakallah, Dr. Ismail. This is the end of our Elizarov session today. And for shield distribution, I will invite Dr. Peer Abdul Latif Qureshi. Please, sir, come forward to distribute the shield to our esteemed panelists. Professor Nazri bin Yusuf, please, sir, come forward to receive your shield. Yes, sir, please. Jazakallah, sir. Professor Masood Umar. Professor Dr. Masood Umar. Professor Amir Jalil. नहीं है. Professor Amir Jalil. I will request my professor Dr. Asadullah Makhdoom, please sir come forward for to distribute shield to the Peer Abdul Latif Qureshi. Sir, आपकी खुद की. जी sir. Thank you, sir. Sir, आप ठहरे ना. नहीं सर, अब क्या ना. डॉक्टर हारून रशीद. हैं सर. सर आप ठहरे ना. Thank you, sir. Professor Zamir Sumro, sir. Shoaib sir, मेरा बात सर, Shoaib की नहीं है बात. बाकी distribution
आप हैं ना? Dr. Abdul Rahman, please receive the shield from Professor Peer Abdul Latif. Abdul Rahman, sir. Thank you very much. Now we are inviting to the hand surgeons. Please come and start the session, sir. Dr. Talha Khalil, he is the moderator of this session.
Eu quero um escopo. Hani? Geliyorum. Double. जब उधर जा रही
Bismillahirrahmanirrahim. Qul huwallahu ahad, Allahu samad. Lam yalid wa lam yulad wa lam yakul lahu kufuwan ahad. Sadaqallahu al-azim. So let's start with the session of hand and wrist in the 36th International Pak Orthocon 2023. I would like to welcome all of you. Especially, I would like to thank especially Professor Pervez Hashmi from Aga Khan University, Professor Harun Rashid from Aga Khan University, Professor Syed Kamran from Indus Hospital, Professor Khalid Masood from Health Center, Lahore. And thank you so much, sir, for your arrival. So we will have some state-of-the-art lectures in this, and we will have some free paper presentations in this talk, in this session. So let's start with the first state-of-the-art lecture of Professor Tahseen Cheema, who is our mentor, great teacher, and he is the pioneer of hand and upper limb surgery in Pakistan, and he is the hallmark of hand surgery. So, Sir Tahseen Cheema. Sir, could you please start your lecture?
क्यों ये कैसे पता चला?
हेलो सर, आवाज आ रही है आपकी? स्टार्ट करें प्लीज।
और स्लाइड भी वो स्क्रीन शेयर हो रहा है?
यस सर, क्लियर है बिल्कुल।
All right, so
You may start.
I'll start. I will start with by thanking the organizers and asking me to deliver this talk. Also, I would like to commend our president and the executive board for achieving a milestone in the history of POA by conducting online election despite all the hitches and glitches. And I would like to congratulate the successful candidates, especially Masood Umar, for showing that if you contribute long enough professionally and academically, it won't go unnoticed. So my topic is the art and science of tensioning and tendon transfers. Tendon transfer is one of the essential part of orthopedic and hand surgery. With this, we are able to address the partially paralyzed situation, and also we are able to address the unbalanced situations in musculotendinous situations. We are familiar with all these basic principles of tendon transfer, which are related to patient, like you have to achieve tissue equilibrium or homeostasis before embarking on any surgical intervention. Soft tissue should be free of scar. There should be stable neurological status. There are some principles related to the motor or the muscle you're going to select. It should be expandable. It should have adequate power. It should have amplitude required for the job. And a synergistic transfer is better than non-synergistic, and the muscle should be non-fibrous and non-innervated. And there are some principles related to the route. It should go through the supple subcutaneous tissue. Vector should be as straight as possible. If you have to go through a facial tissue, one should make a large window, and multiple small incisions are better than a long longitudinal incision, which will probably bind down your transfer by scarring. And then there are some principles related to the recipient side. The joint should be supple, and then comes the topic of this lecture, that one has to adjust the tension. And with that tension is related the concept of moment arm and also power and the amplitude. As I say, that tension, adjusting tension is the real art of tendon transfer. But we will consider some science behind also. I agree that that's still partly art. When we say it's art, that means science is not properly understood or is not properly applicable. One should understand that given the property of a recipient muscle and the jointed motors, the choice of appropriate muscle is among the elements critical to the success of the transfer. Because muscles do have discrete properties. The donor muscle actually serves as a substitute and not a true replacement. Because every muscle is unique, its action is unique, its fiber length is unique, its arrangement is unique. It really cannot be replicated. One can just substitute as good as possible. There are 4 essential points. A surgeon must know how the muscles are designed, how they work, how they adapt to a new situation, and how to set them during the transfer. And that's where the key question is, are we adjusting the tension or are we adjusting the length? We'll address to that. This is very important, that how much force we need. For example, if we're doing any transfer for the elbow flexion, it has to lift the arm up, and any load which is hand is holding, that is quite obvious. One has to have this much power that one can lift the arm and any other load which is being held in the hand. But in addition, there is a third force which is forgotten many times, and that is the elastic recoil of the antagonist, the triceps. There is another factor. Muscle force would be determined by its moment arm from the center of rotation of a particular joint. And every joint is then unique. You see, if the moment arm is the distance from the center of rotation to where muscle is attached, the more this distance is, the more power muscle can exert, but then it will need more amplitude to go through the full range of motion. Closer it is to the center of rotation, it will need more power to do the job, but they will need less amplitude. Now let's see what the muscle is made of. The sarcoplasm of a muscle fiber contains parallel thread-like myofibrils, each composed of myosin and actin filaments. The muscle fiber length is the single most functionally important structural feature of skeletal muscle. Muscles of the upper extremity have a wide range of fiber length, which directly determines the excursion and the velocity of the muscle itself, and has major implications with regard to the surgical tendon transfers. Muscle fiber length at the microscopic level is a simple reflection of the number of serial sarcomeres arranged along the fibers at the microscopic level. This is a graphic representation of a muscle fiber. There are actin and myosin fibrils. But then one thing which is generally ignored, that there's a collagen element. And that is the element which would be responsible for elastic recoil and for stretching, which causes some tension in the muscle. The structural organization of the skeletal muscle needs to be understood. The sarcomere is the basic structural unit of the muscle fiber. The alternating dark and light bands give muscle its striated appearance. That's why we call them striated muscles. The A band contains the thick, rough myosin filaments surrounded by 6 thin, smooth actin filaments. The I band contains only thin actin filaments. I think this slide should be needs to be understood more clearly. This is, if you, I don't know if you can see the myosin fibers, which are surrounded by actin. And there's the overlap. This overlap is necessary for when muscle is stimulated. This interstriation between actin and the myosin, that will help to bring the Z lines close together, and that's what will cause a muscle contraction. And the force which is applied depends upon this striation and this connection between myosin and actin fibers. But there's then a third element, that's titin, that's collagen, and that's a non-contractile collagen or proteins. And when there's a passive stretch of the muscle, this will give you the passive recoil without contraction. What is the relationship of the sarcomere length to the contraction potential? This is, I think, very important concept, and this figure, you should look at it a little bit more closely. The best contracting force is when muscle is at resting length, which is right at the center. And that is the time when there is maximum of optimal overlap between myosin and actin. So myosin, when contracting, it can pull the Z lines together. If muscle is stretched too much, which is on the right side of your screen, You see, there is very little overlap between myosin and actin. So it has very small power to contract or to bring the Z lines together. And that is the situation when you overstretch a muscle, you put it too tight, it will lose its contractile powers by a quite significant number. And on your left side, when muscle is loose, there is no further place for Z lines to come together. This is already too close. So maximum contractile power is at a resting length, and this is a very important concept. One should be familiar with this Blix curvature, which Magnus Blix described in the 19th century, around middle of 19th century. That describes the relationship between tension in a muscle and its length. And there are two elements, and I think that's his contribution, that he recognized there's a contractile force which causes the tension, and then when we do the passive stretching, that is then because there is a collagen element within the muscle, or you can pull the muscle.
Recording in progress.
Okay. So that is another element. And the resultant tension in the muscle would be combination of these two forces, the contractile power of the muscle and the tension which you create by stretching the muscle. But yeah, issue हो गया. अच्छा. ठीक. Okay, we are back to Blix curve. The tension capacity of a muscle alters a little from that present at resting length and that present with the stretching. And you see, that remains fairly constant. But when you overstretch it, its contractile power suddenly falls down. So overstretching, you can feel the stretch or tension in the muscle, but it loses its contractile power, and in your tendon transfer, it probably would act just like a tenodizing effect. At the limit of the stretch, the tension that muscle can exert is mostly due to passive elastic recoil. But the tension present in a stretch muscle is the sum of the active tension provided by the muscle fiber and the passive tension provided by the tendon and the membranes. But then Brand introduced another factor that we should not, as at the start of the lecture I said, there is a third element, that's your antagonist muscle. This part of the lower part of the curve, there's a passive stretch of the opposing muscle. That will also affect the total tension compared to our graft against the length. Brand modification of the Blix curve demonstrates the functional length tension curve of the entire muscle with the elastic curve of the opposing muscle subtracted from the active output of the primary muscle. This partnership demands an appreciation of the balance rather than the knowledge of the individual muscle mechanics in practice of tendon transfer. Muscle function is determined by its length, not by its tension. Now you see, when you overstretch it, you lengthen the muscle. Then you actually reduce its contractility. A muscle resting length represents the position from which the muscle can generate its greatest force, and it is reflected by the muscle fiber length, which depend on its sarcomere length. Muscle with longer fiber lengths tends to maintain their force of contraction over a longer range of motion than muscle with short fiber length, whose length tension curves tend to rise and fall quickly. The common dogma that muscle lose a grade of strength after transfer is poorly understood, but it is often explained by post-operative adhesions and the factors that donor muscle is a substitute for biomechanically distinct recipient muscle, and that transfer line of pull may be different from that of the recipient muscle. Hence, many surgeons are taught to set the donor muscle tightly during transfer because muscles are thought to stretch and weaken after the surgery. Understanding the concept of sarcomere length would suggest that putting the muscle on stretch sets the muscle at a length longer than the sarcomeal natural resting length, which is well into the passive part of its Bliss curve and at a biomechanically inefficient starting tension. We generally tend to put too much tension. We are taught that we should err on a little tighter side, and that will put the sarcomere length a little longer than the resting length and make it less efficient. Setting the donor muscle near its normal resting length is probably optimal for force generation. Short of actually measuring the sarcomere length, how we are judging the muscle resting length during the surgery is a guesswork. You cannot really judge the sarcomere length. And the gross appearance of the muscle, whether it's feeling tense or that, is not a good measure of the sarcomere length. The only objective method of determining whether on the Bliss curve a muscle operates is to either measure its internal sarcomere length or measure its functional properties by physiological testing, which are both kind of unpractical things. People have tried in experimental situations, try to measure the sarcomere length intraoperatively by laser distraction. So not a practical thing in everyday surgery. And the general conclusion was that most of the tendon transfer, they were put under too much tension. Now, the concept of adaptation of the muscle after tendon transfer. The classic experiment in the 1970s demonstrated clearly that rat and cat soleus muscle adapt to the chronic length changes after immobilization by re-optimizing their sarcomere number. So if they are put too loose, more sarcomere will add, and so on. So concept was that muscle has the capacity to readapt to the new situation. More recent experiments have demonstrated that this rule of muscle adaptation does not apply to all muscles and does not apply to human muscles. The fact that surgeons agree that an under tension muscle will not tighten after tendon transfer provides anecdotal evidence that these muscles are not re-optimizing in the transfer position. So that experimental evidence that muscle can readjust to the optimal tension in new situation is not really applicable in the human being. Even though it is true that fiber length is good predictor of muscle excursion, it is not true that intraoperative excursion demonstrated by pulling on a tendon during the surgery reflects fiber length. Passive excursion does not scale with fiber length. Passive excursion itself is highly variable depending on the degree of muscle release and the feeling in the surgeon's hand and so on. There are many factors. A muscle resting length represents the position from which the muscle can generate its greatest force and is reflected by the muscle fiber length, which depends on its sarcomere length. Using sarcomere length would allow the surgeon to set the tension of the donor muscle to the ideal sarcomere length and allow maximal contraction over the largest distance. Now, something about the muscle architecture. How does that affect the tension generated and also the amplitude? Architecture or the orientation of the muscle fiber within a muscle, not its mass or volume, determines its function. Architecture feature of a muscle or its fiber length, orientation of muscle fiber relative to the axis of fourth generation, which is called pennation angle. At what angle the muscle fibers are attached to the tendon of the muscle. And what is the physiological cross-sectional area? This is important to know that how are muscle fiber organized. Parallel fiber arrangement in the muscle, if they are parallel to the longitudinal axis of the muscle, that will give you more amplitude. Pennate fiber arrangement, short fiber which are attached to one or more tendon within the muscle, that will increase the number of the fibers and will give you more power. This diagram will help you understand this concept. If fibers are parallel, that will give you more amplitude. If fibers are attached to the tendon at an angle, then this angle is important because cross-sectional area there would be more muscle fibers that will give you more power, but its amplitude would be less. It's like a gearbox. Now you will have less amplitude but more power when there are more muscle fiber, but they are attached to the tendon at an angle. So this concept is important to understand. As the fibers contract, your angle of pennation, that also increases. There are a few other factors, like moment arm, muscle crossing multiple joints. You should understand the vector and what is the balance. This took me a long time to really appreciate that if I'm doing a tendon transfer for fingers to flex, all proximal joints needs to be stabilized by the group of muscles. Like a wrist joint needs to be stabilized by wrist flexors and extensors, MP joint needs to be stabilized by the intrinsic, which are flexors, and by the extensor, which are the long extensors. So all these joints need to be stabilized before my tendon transfer can flex the fingers. This element is usually not appreciated. When muscle crossing the multiple joints, if proximal joint is not stabilized by a separate set of muscles, your transfer might get all expanded on the proximal joint instead of the joints for which it was intended. So this is about the science, understanding the sarcomere, understanding the resting length, understanding the architecture of the muscle, pennation angle, whether the fibers are parallel or they are attached to the tendon angle. But you see that science is not easily applicable in a day-to-day clinical or surgical situation. So still there is a lot of element of art. Now let's talk about the art of the tendon transfer and adjusting the tension. And now you have realized that tensioning is a kind of misnomer. We should be aiming at achieving the correct length of the muscle, which will generate the contractile power. So these are some general observations that in lower motor neuron lesion like polio, like paralysis, nerve paralysis, you err on slightly tighter side. In upper motor neuron lesion, you err on a slightly looser side like in CP. Tension is best judged while the extremity is placed in the position it will assume when the transfer tendon contracts. After the attachment, transfer tendon should hold the target joint in about mid-position. This is, I think, a good general rule. If you have transferred the tendon for the wrist, let's say for wrist extension, after your first one or two stitches, you want to test it, it should be able to hold it in mid-position, that is close to neutral. For postural transfers, such as restoring the elbow or wrist extension, these tendons must have maximum tension on them so that only 50% of the movement amplitude against gravity is restored. This means that a wrist extension transfer must be tension so that flexion against gravity does not exceed neutral position. I hope this point is well understood. Transfer aimed at restoring finger actions have some special consideration. The tension must be such that when restoring the flexors, the fingers are practically fully closed by the wrist extension only. When you extend the wrist, finger should be closed by its normal tension, while maintaining full extension of the finger when the wrist is flexed. The same principle applies to restoring the finger extension. The transfer must be tension so that it produces MCP extension up to the neutral position of the wrist when straight, while maintaining full flexion of the fingers when the wrist is extended. So, after your initial attachment, you put the wrist through a range of motion and see how it affects your flexors or extensors of the fingers. This is a recommendation by Goldner, a very wise man in the hand surgery. The extremity and the recipient tendons are positioned in functional position, and tendon to be transferred is the position in the resting position. Then you apply traction to the tendon to be transferred, and the distance is marked in the wound. 60% of this distance between the resting and traction length is marked as a position of the transfer tendon when the final insertion is initiated. I think that's a good general rule. In addition to that, it should hold the joint kind of in mid position, like a wrist in neutral of the transfer. Recommendations of the Kuni are how he adjusts the tension. The distance that muscle to be transferred contracts after release from its normal insertion. Once you release, see how much is the distance muscle retracts. The lost length is restored at the time of transfer, plus slightly more tension to pick up the connective tissue elasticity within the muscle. The tunicate is deflated when final tension is set so that muscle ischemia does not contract the muscle to such a degree that tension is too loose. This is another way of adjusting the tension. For extensor tendon, the resting tension should be strong enough to hold the extremity passively against gravity, like this wrist is being held in neutral position. For wrist extension, when you adjust the tension, the transfer should be able to hold the wrist slightly above the neutral in lower motor neuron lesion and close to neutral in upper motor neuron lesion, like in CP. However, one must be sure that the wrist has potential for functional flexion. It should not be too tight that you cannot, the wrist won't flex later on. This is one example. For properly tension, one should be able to extend the wrist, but it should allow inflection because some wrist flexion would be necessary for the finger to be completely extended. For opponent's plasty, these things are important, that suppleness and passive range of motion of the thumb. First web space should be supple and open. Other associated palsy would also affect, and the motor you select. The common motors are extensor indicis proprius or flexor digitorum sublimis of the middle ring finger, or the Hubert transfer you see in lower picture, the abductor digiti minimi. Each has its, like in when you are using the extensor indicis proprius with wrist slightly flexed, if it is properly attached, it would pull the thumb into position of opposition. In the intrinsic replacement, all the joints should be supple. Duration of paralysis and the status of the PAP joint also affects your results. Generally, there are two motors like FDS in Banal style transfer or extensor carpi radialis longus in the brand transfer. And adjustment of tension is different in each. A banal style operation, when you use one of the sublimus and divide it into 4, the tension is adjusted so that fingers are in intrinsic plus position with the wrist in neutral. That's important to understand. And still there is a possibility when patient will flex the wrist, your attachment might be little loose. Brand has a great impact on the hand surgery. He was a very remarkable person, born to missionary parents in India, went back to England, got his training and came back to India. He did most of his professional work in South India, and that's where he was treating the lepers, and he was kind of unsatisfied with the available intrinsic replacements, so he developed his own operation, which is brand 1 and brand 2. In brand 1, he uses the extensor carpi radialis longus and brevis, extends it with the tendon graft, stays on the dorsal side and passes it transferred through the interosseous space. The tension is adjusted with the wrist in extension and MP joint flex with increasing tension from index to small fingers. In brand 2, where it passes through the carpal tunnel, the tension is adjusted to hold the fingers at MP joints with the PAP joint in extension with the wrist in neutral. So brand 1 and brand 2, those are slightly different operations, and tension adjustment is different. In elbow flexorplasty, whether you do Steindler flexorplasty, latissimus dorsi, pectoralis major, for Steiner flexorplasty is relatively simple. It is that the distance you move the common peronator flexor region, that will determine your tension. But at the end of your fixation, it should hold the elbow at about 90 degrees. It will, with the optimum result, it will allow some stretching close to 30 degree of flexion. From that position, patient should be able to flex the elbow above 90 degrees. With latissimus dorsi and pectoralis major, tension adjustment is more difficult, and probably one should err on, so that after you attach it to the biceps tendon, it should hold it close to 90 degrees, but then you should immobilize it in even more flexion, that's close to 120 degrees. So this is, now you see, what's the disparity between the science and the art. We understand some of the science, but it is difficult to apply those science in the clinical situation. So we still have to rely on our good judgment. As they say, that good judgment comes from experience, and experience comes from some bad judgments. Hopefully this is these concepts are useful to you. I will stop here and entertain any question from the audience, if any. Thank you. Ji, Kamran Sahab.
Assalamu alaikum, sir. Sir, can you hear me? Huh? Sorry? Sir, sir, it's such a blessing to hear your lecture. But as you know, most of the orthopedic surgeons do think less about the science, think more about the art. So I think they are going to take more from the last 4 slides and probably They were like, hidden under the Blix curve. But I think it's a very big eye-opener. We should know about the exact muscle and the construction of a muscle and what is happening when we do a transfer. Obviously, at the end of the day, tensioning the transfer, which I have learned from you, really something that as an art as well we need to understand. So I think it's a very good sort of a reminder. And personally speaking, it took me a long time to understand this art of tensioning. And then it somehow, becomes part of your thinking process, and you know what you are doing. But again, going back to the science, I think it's critical. Very important to understand what muscle can do what. The difference between amplitude and strength, what is the difference, how do muscles work? I think something that we all need to think about. Sir.
Thank you, thank you. I miss being there, but I couldn't get a flight from Bahawalpur, Multan, or Rangar Khan, and didn't want to be on the road for 12 hours, either on the train or on the road. So this, I think, Zoom is a great invention, and that still allows me to participate. Thank you for allowing me to give this talk.
Sir, can I ask a question, please?
Yes, yes, please.
Sir, we are really missing you, and meeting is missing you. Or regarding this tendons and tensioning art, although we are all doing with this this mechanics, but the results still they are most of the time ununderstood. What could be the reason? There are so many experiences that people have shared with us, particularly if we transfer a flexor tendon like like FCR or FCU to a group of extensor tendon, it works very well. But if we transfer an wrist extensor tendon to a group of flexor tendon like FDP, the results are not so good. So what could be the reason in your experience, sir?
So, you see, when we use one of the wrist mover, whether that's a flexor or extensor, to mobilize the fingers, their amplitude don't match. For fingers to flex fully, we need about 70-degree amplitude. And all wrist movers, whether extensor carpi radialis longus or extensor carpi radialis brevis, their amplitude is 30 degrees. So unless that is supplemented by wrist extension, you will not get full flexion. So in situation where, let's say, we first fuse it like in brachial plexus, sometimes we have to fuse the wrist. Now when we will do the tendon transfer would not be as effective. And this fact is not generally realized. Even for finger extension, let's say we fuse the wrist to spare the flexor carpi ulnaris. Now wrist is fused, we have put the flexor carpi ulnaris into finger extensors. Now we don't have that luxury that patient can fully extend the finger by slightly flexing the wrist. So that's interplay between the proximal joint and the terminal joints. I think that has a lot to do with the ultimate result. And it is creating the balance. You see, it is not just balance between with the prime mover and the antagonist on that particular joint. It is the situation of all proximal joints also matters. And that makes things more difficult and more complex. So that's my understanding on that.
Sir, thank you very much.
बहुत अल्लाह, thank you. ते आज शामी जनरल बॉडी मीटिंग है?
पता नहीं सर, मीटिंग है कि है, कुछ ना कुछ तो है सर.
Let's hope for peace for everybody. Thank you, everybody.
I hope so. I hope so, sir. Thank you, sir. Thank you.
अस्सलाम वालेकुम।
अच्छा, एक वो मैंने कमेंट लिखा था कि जितने हमारे the people who were so ferociously and valiantly fighting just 2 days ago, we don't see them in the clinical sessions. So there are two parallel streams. Those are the one who want to attend the clinical session, and those are the one who want to fight. And they go side by side for, they are kind of parallel streams. Thank you, everybody.
Thank you so much, sir. That's a beautiful lecture on the biomechanics and the art of tensioning. Thank you so much, sir. Now I would like to request Professor Parvez Hashmi from Aga Khan University to please come and deliver the lecture on US policy, early and late management. Professor Parvez Hashmi.
Bismillah ar-Rahman ar-Rahim. Dear colleagues, Assalamu alaikum. Of the talk of Dr. Tehseen Chima, who is our teacher, mentor, and everyone sitting here actually owes a lot to him because we are his student. I'm the first student who came here in AQH, followed by Dr. Harun Rashid, and then many of us, although some of them, they are my student also, and they have actually good name. Now, my talk regarding brachial plexus, I do a lot of actually brachial plexus work. Just I want to know how many of you are doing any brachial plexus work, especially in the children, birth-related brachial plexus palsy. Although many people, they do a tendon transfer in a late stage, but anyone who is doing a brachial plexus in an early stage. So none of you. Probably this talk would be then, maybe it would be a little boring for you people. So the pattern of my talk would be like I will go through a definition, anatomy, etiology, clinical features, and maybe I will talk about some peripheral nerve injury, grading of brachial plexus, and then treatment options in an early stage and the late stage. So this is the kind of work, actually I'm proud of it, and I do with a lot of interest, devotion and dedication, and I have a pretty good result on this in early children. So just for the students, we know this slide is only for the anatomy of brachial plexus. We know that C5, C6 unite to form upper trunk, C7 continues as a middle trunk, and C8 and T1, they unite to form the lower trunk. Now, before these trunk formation, there are actually branches which arises from those respective roots, dorsal scapular nerve for the rhomboids, then the long thoracic nerve, which comes lower down, and there's a contribution to the phrenic nerve. Those are the branches which come from the roots. Then from upper trunk, only the two branches arises. One, which is the most important nerve, is the suprascapular nerve. So it is fixed at this point, Urs point we call, and then the second point of its fixation is at the suprascapular notch, where it enters through the notch and underneath the transverse ligament, which we call superior transverse ligament. Over the ligament passes artery. So that supplies the supraspinatus and infraspinatus. This nerve is very, very important. The other nerve is nerve to subclavius. It's not actually too important. Then we know that there is a middle trunk, and then lower down you see these lower trunk. They respectively divide into further anterior and posterior division. Three posterior divisions, they unite to form the posterior card. while the anterior deviation of upper, it continues to the lateral cord, while anterior deviation of interior and lower cord, it continues to form the medial cord. So respectively, we have 5 branches from each. This thing I have just told you. From the lateral cord, we have a lateral pectoral nerve, which actually supplies the pectoralis major muscle mostly. Then musculocutaneous nerve, which supplies elbow flexors. And then it continues as a cutaneous branch, lateral cutaneous nerve of forearm. Then it also contributes to the lateral root of median nerve. Then going to the medial cord, there are again 5 branches. Medial pectoral nerve, this is very, very important nerve for me because I utilize it for neurotization of an axillary nerve. And still I have to publish that because literature is scanty on that. Then medial cutaneous nerve of arm and forearm. And then there are 2 terminal branches, medial root of a median nerve and the ulnar nerve. Later root of median nerve, it supplies 3 muscles. And those 3 muscles, they are pronator teres, flexor carpi radialis, and the palmaris longus. So these are the 3 muscles, they are supplied by the later root of median nerve. While the medial root, actually, it supplies further its muscles, which are actually flexor digitorum superficialis, profundus of index and middle finger, and the intrinsic muscle of thumb, and especially flexor pollicis longus, pronator quadratus, and thinner muscle and hypothenor muscle, and the radial 2 lumbrical muscles. So that's the distribution. While posterior cord, it gives upper subscapular, lower subscapular to the subscapularis muscle, and in between is a thoracodorsal, which is very important nerve for isthmus dorsi. Then its 2 terminal branches, they are the axillary and the radial nerve. So this is a generic contribution, but if you look at this slide is the most important slides for any brachial plexus surgeon. One should know that if C5 nerve fibers they are going, although there is an intricate mechanism, they passes through the divisions, trunks, and further roots, where the C5 branches they will go. Predominantly, C5 fibers only go to the 2 major nerves, suprascapular nerve and the axillary nerve. Axillary nerve supplies the 3 part of a deltoid and the teres minor muscle, while the suprascapular nerve, it will supply the supra and infraspinatus muscle. Now you can imagine the C5 nerve is controlling your shoulder motion. Suprascapular nerves will supply supraspinatus, infraspinatus, and the axillary nerve will supply all 3 components of a deltoid and the teres minor. So except subscapularis muscle, everything is being controlled by C5 in the shoulder. So the C5 is only for the shoulder. Then if you trace the fiber of C6, they go to mostly to the musculocutaneous nerve. And C6, it will supply 3 muscle, conjoint tendon, short and cracobrachialis and short head of biceps, long head of biceps, and the medial half of brachialis muscle. So it is the most important nerve, majority of its nerve fiber. It's not 100%, like 80% of the fiber, they will go here. Then comes the C7, and the C7, it will supply the whole extensor compartment of upper limb. Everyone knows that from triceps and the 12 muscles of forearm, all extensor muscle. But fortunately, unfortunately, you see the Robert Gu in 1988, when he actually did an experiments in the animals and then ultimately in the human being, he severed C7 immediately before the division. Once as the C7 divides into anterior and posterior division, immediately at division when he severed that nerve, there was no distal functional loss. So this was an amazing thing because only people, they had developed little sensory hypoesthesia in the index and the middle finger, the rest of the hand and the function was okay. So that prompted him for all 5 root avulsion opposite C7 transfer. That brought the concept. I thought that he should have given Nobel Prize, but unfortunately he is a Chinese, and the European and American, they did not consider his actually contribution. Then comes the C8. C8, I think it is for the extrinsic muscle of your flexors, like for the wrist flexors and the finger flexor, profundus and superficialis, and the T1 is for the intrinsic muscle. So this is, that's why I said this slide is very, very important to understand if you are trying to understand any brachial plexus things. So this is the same thing which I have elaborated in a written form. And then there are 2 actually contribution which we call white communicants and gray communicants. These are the actually fibers from the middle cervical ganglion and from the cervicothoracic ganglion, synthetic contribution which goes. This is very, very important, especially if you want to understand the concept of a Harner syndrome, how Harner syndrome occurs. So for just refreshing your knowledge, this is a cross-section of a spinal cord, and you can see here, these are the actually rootlets, interior motor, small rootlets which form the very small nerve here interiorly, and then there are posterior rootlets which you can see here, and posterior rootlets actually, they immediately enter into the dorsal root ganglion. So first order neuron for the interior rootlets lies in the interior motor horn cells, while the first order neuron for the sensory component is lying in the dorsal root ganglion. So this is very, very important to understand. That's why I'm saying whenever we talk about a root avulsion injury, we always say it's a preganglionic, post-ganglionic injury. In a preganglionic injury, injury would be here. This pointer is actually not working, maybe so something is wrong. Here at this level where the rootlets they are avulsing. So when the roots they are avulsed, you will see that the dorsal root ganglion is intact. And especially when you will do a sensory examination, especially an EMG nerve conduction, there would be some sensory receptors that would be intact. So this is another important concept to understand. So this is a cross-section of a peripheral nerve. We know that nerve is surrounded by a completely outside structure which we call epineurium. Then there are bundles, and each bundle is surrounded by perineurium, and then microscopically small, those fascicles, they are surrounded by an epineurium. Thank you. Yeah. So if you want to look at the microscopic structures from an axon, actually this is an access sheath which moves out, and this access sheath you can see surrounded by a myelin sheath, and then in between you can see the nodes of Ranvier. And to understand the nature of injury, we know that there are two classifications. One is Seddon's, and another is Sunderland classification. In Seddon classification, we say it is a neuropraxia, and the other is a axonotomesis, and third one is a neurotomesis. But in a neuropraxia, your tinal sign would be absent. Why? Because there is no structural damage. It is only temporary cessation of nerve impulses. Similarly, in a neurotomesis, tinal sign would be again absent. So this is very, very important to understand the grades of nerve injury if you are understanding the pathophysiology of a peripheral nerve injury. Now, we know that the birth-related brachial plexus or obstetrical palsy, it was initially described by Smelly in 1764. And if you look at its incidence as a variable literature, they have described 0.1 to 0.4%, and other people, they have described even up to 2.6 per thousand live birth in academic literature. Now, the Erb's palsy, it was described by the Erbs in 1877 in the children, while the Klemke's, it was described by 1885 when all 5 roots, they were involved. And the etiology, we know that it mostly happens to people who have increased birth weight, prolonged labor, primigravida, vertex presentation, even a breeze presentation, if there is a forceps application. So once head has been delivered, the shoulder has to be delivered, and usually either with the forceps application or the person, he or she who is delivering the baby, they will give a little jerky motion, and there is a stretch over the upper trunk most of the time. And C5, C6 nerve roots, they can be actually stretched out. If they are just stretched, you will say it's a neuropraxia. But the stretch can go certain limit, then there is a mixed injury where would be some of the nerve fiber would be stretched, some would be go through an axonotomesis. And the third stage comes when all those nerve fibers, they have been avulsed, where you say it is a neurotomesis. So that's how actually those kids, they present. Here I just described that what is the mode of injury and attraction, that sort of injury. Now, clinically, you see when the child is born, immediately, usually obstetrician, when examined within 24 hours, they see the arm is lying listless, and there is no motion at the elbow and the shoulder. It is in a waiter tip position. And the parents, if they recognize early, they will ask the actually pediatrician or other people, that's what's happened. And most of the time when I receive a consult, it is usually for the during the first week, and when the baby and the mother, they have been discharged from gynae ops ward, and they will follow me in the clinic. Now, when all 5 roots, they have been avulsed, you can see here an element of a the Harner syndrome. We see meiosis, ptosis, anhydrosis, and anarthal mass. In those children, it can be seen when all 5 roots, they are avulsed and there is no motion in the whole upper limb. Now, clinical presentation is usually persistent, and here the serial examination is very, very important. It's not just one examination that come first week and I will say it's a fine, the kid is fine. So I usually call after every 4 to 6 weeks the kids, tell the parents that, okay, this is a sort of a stretch which will improve over a period of time. What you need to do certain passive exercises, physiotherapy. I usually teach to the parents that elbow motion, shoulder motion, and I will talk in a minute that what motion usually we advise. And these motions, most of the time you see our physiotherapists, they are not trained. They do not even teach those exercises. When C5 is injured, we know that at the shoulder only C7 innervation is there. Subscapularis is intact. So subscapularis will keep the arm in an internal rotation position. And with that, there is no motion at the shoulder, C6 is involved, so there is no flexion at the elbow. So the one you advise them flexion extension, and the second you advise them with an elbow flexed, arm adducted, internal rotation. You can look at me, 0 position and external rotation. And at the same time, you tell them arm abducted 90 degree, elbow 90 degree flexed, external rotation, 0 position, internal rotation. This is the most important thing. And later on, we also tell them to put the child in a brace if during 3 months period of time they do not recover, just like a hip spica type, a pelvic band, and with an external rotation, so that during the night time when the child is sleeping, they keep it in an external rotation position. But most of the time, it is physiotherapy, because injury 95% of the time is a neuropraxia, and there would be recovery. So natural recovery, it happens in these kids. So this is a typical Erb's palsy. You can see the posture of hand, internal rotation. Historically, you see, there has been poor use of, we don't have a lot of an evidence, and those kids, they are not actually referred in a very early stage. And timing of referral is very, very important. And again, we will talk about that apart from a conservative treatment, there are certain indications in only 5 to 7% of the kids where they do require surgery, and what are the indications for those surgeries. So Canadian guidelines, I will just actually go through those. In Erb's palsy, when pattern of involvement, if C5, C6 is involved, shoulder and elbow will be involved. If C7 is involved, you will see also the wrist drop. And sometimes there is a total paralysis, or sometimes there is a Klemke's paralysis. And occasionally when the hand was prolapsed, lower root they can be avulsed, only C8 and T1, they would be involved. So as I said, that diagnosis is very, very important, but you need a repeated examination. Spontaneous recovery usually occurs within a 4 to 6 week period of time. It starts recovering in case of a neuropraxia. And I will actually come through those scenarios and talk about that at what stage this recovery occurs and when you will actually advise them in intervention. So spontaneous recovery in the biceps by the 3 months period of time, more or less it is agreed that it is a neuropraxia and the child will have a good recovery. So you will continue with those physiotherapy exercises and tell them that it was a neuropraxia. As the child has started to move the elbow, slowly and gradually shoulder elevation will also come. So if there is no recovery in the biceps in 3 months period of time, it means the recovery is beyond neuropraxia. So I need to get EMG nerve conduction and maybe MRI of C-spine or the myelogram. And neurophysiological examination, I only get after 3 months period of time, not quite quickly, but the children sometime who are referred to me, they have been to especially neurosurgeons, and neurosurgeons, they are fond of getting actually especially MRI and EMG nerve conduction at 6 to 8 weeks period of time. But one should not get actually too early because it takes little time for this thing to recover. So this is just an example. You can see if there is a root avulsion, one would see myelomeningocele actually at the site of a avulsion of those roots. So this is a busy slide, but this is a Canadian protocol. What they suggested, if all 5 roots are involved, usually intervention would be if it is required at 9-month period of time when there is no recovery. But if there has been a partial involvement, there are different scenarios that if recovery is at 1 month period of time, then you will actually just continue with the physiotherapy and recovery will occur. At 3 months, there are still chances of recovery. At 6 months, if there is no chances of recovery, here you may actually do some intervention, and intervention is especially exploration, nerve repair, nerve grafting, or nerve transfer, which we will talk about in a minute. Now, if you look at the natural history of a brachial plexus, 75 to 95% of the cases they recover spontaneously. And the treatment would be a conservative treatment. And here, what are the poor prognostic factor in which the recovery will not take place? If there is total paralysis, if you have seen a Harner syndrome, if phrenic nerve was involved, and the speed of recovery of biceps is very, very important. Earlier the recovery of biceps tendon, there is good chances of recovery. And if the biceps function does not come over a period of 6 months, then it means it is a bad prognosis. So the first scenario, this is for those people who actually treat Erb's palsy. This is very important for those people to understand. First scenario is that initial 2 to 3 weeks, forearm sling, collar and cuff you have given, maybe body bandage, and monthly examination, you are checking for the biceps. And you are doing the physiotherapy, range of motions at the elbow and the shoulder is continuing. External rotation with the arm adducted and abducted, as I explained, it is very, very mandatory. Biceps recovery, if it starts occurring at 4 to 6 weeks period of time, there is a good chance of recovery. Just monitor recovery in deltoid and external rotation. If external rotation improve in a 3 months period of time, happy ending, no further workup, only continue with the physiotherapy and exercises which you will teach to the parents. Now, there is a second scenario. When recovery occurs not at 4 to 6 weeks, now recovery in the biceps is occurring at 3 months period of time. Now here, you can do EMG nerve conduction just to see that maybe you can do MRI C-spine also, just to see if the C5 is coming back or not. If external rotation and shoulder elevation returns at 4 to 6 months period of time, again I would be happy and I will continue with the same conservative treatment. So in first case, 4 to 6 weeks, happy ending. If it is 3 months and 6 month period of time, deltoid is coming, chances are that it is going to recover. Now there is a third scenario when the biceps recovery is at 3 months, but there is no external rotation at 6 months period of time. Now that is the time when you should think of doing EMG nerve conduction and repeat it maybe after 4 to 6 weeks and see that if there is no chance of recovery in the external rotator and the shoulder muscle, then you will actually think of doing surgical exploration. And in surgical exploration, you can actually do repair, nerve grafting, neuroma, especially when you explore it, there is a neuroma in continuity. And if neuroma in continuity is there and it's a conducting neuroma, you will do just neurolysis and only one nerve transfer. And one nerve transfer would be a spinal accessory motor branch to the suprascapular nerve. This is almost now universal. Every pediatric brachial plexus surgeon, if they will do it, and that gives an excellent result. Now the fourth, here continuing the third scenario, if the neuroma of C5 is non-conducting. You see, you have explored the brachial plexus, neuroma was in continuity and it was conducting. Conducting neuroma means you stimulate with nerve stimulator proximally with the smallest millivolts and you will see contraction in the muscles distally and the deltoid. It means the chances are there would be recovery. But if you stimulate the nerve proximal to the neuroma and it is a non-conducting neuroma, so there is no contraction in the deltoid muscle, in that situation, what you are going to do? So you have an option of CNF neuroma and doing nerve grafting, or the other option is that you can do a nerve transfer. And the nerve transfer would be spinal accessory to the suprascapular nerve and medial pectoral nerve, which is my favorite, medial pectoral nerve to the axillary nerve, because you are doing it through the anterior approach, just underneath the coracoid process. You lift the pectoralis minor muscle, and there are 3 leashes of medial pectoral nerve. It's not one single nerve. Usually there are 3 leashes. You bind them together, and with the glue, you will actually, with the tenosuture, will do repair with the axillary nerve. So that gives a pretty good results in children as well as in the adults also. Now there is a fourth scenario which you can encounter, that there is no recovery at the biceps at the 3 months. Here you are going to do EMG nerve conduction, MRI, and repeat your EMG nerve conduction at least after every 4 to 6 weeks. And at 6 months period of time, when you see that there is no chance of recovery, ultimately you think that as there was no recovery in the shoulder and elbow flexor, you need to re-innervate the muscle of shoulder as well as the elbow. And those muscles which you will re-innervate, those would be, again, for shoulder, there are 2 nerves. If you re-innervate suprascapular nerve, supraspinatus and infraspinatus will come. When you will re-innervate axillary nerve, deltoid will come, and the teres minor. So the shoulder function will come back. For biceps, we usually do a bipolar nerve transfer. Bipolar nerve transfer means that you will take a motor branch of ulnar nerve going to the flexor carpi ulnaris. Usually there are 2 nerves. One nerve would be transferred to a long head of biceps, motor branch of long head of biceps. And other you will take a motor branch of from the median nerve going to the FCR, or it may be going to the flexor digitorum superficialis. That motor branch you will transfer to the medial head of a gastrocnemius muscle, so that the person will have a elbow flexion. So that is called bipolar nerve transfer. So these are the actually 4 scenarios. This is my protocol. This is my own actually designated. I have yet to publish it, but over a period of last 8-10 years, I have been exploring those brachial plexus and doing this. Whatsoever I have explained in those scenarios, this is written in the whole protocol. Now, the treatment option when you explore those brachial plexus, one is to do a neurolysis, especially for a conducting neuroma, and then microsurgical nerve repair and nerve grafting. It all depends upon the surgeon experience, his expertise, as well as the duration of injury. Earlier, you operate the child, the higher the chances of recovery would be there. But the nerve transfer, they always give a better result as compared to the results of a nerve grafting. So these are the few results. I just wanted to show, maybe I will skip these slides. These are related to the technique, but maybe it is a little boring. I know that in a root avulsion injury, what are the different options, and where you will find a proximal motor branch and distal motor branch where you have to do nerve grafting and repair. These are the different options, especially. Can somebody run this video? Excuse me, video. This is a kid from Lahore, in which I actually did his nerve exploration, brachial plexus, and did a neurotization of his suprascapular nerve, and only neurolysis of rest of the C5. So you can see here, but she will, it was typical C5, C6 injury. We wanted to ask him, I have just actually muffled the whole sound, just you can raise your arm. Now you will see here, ultimately she will raise it and hold it. Mother was asking, can you hold your pony? No. Here you see elevation. Okay. Second video, excuse me, video beta, another kid, this is son of one of our AKUE nursing staff, in which he had C5, C6, C7 injury, and his exploration was done at 11 month, and he did not have any elbow elevation, elbow flexion and shoulder elevation, and okay, next. So now he is 3.5-year-old, and we are planning to do his tendon transfer, wrist drop, and finger extension because he has did not have recovery in the C7 nerve fibers. So there's a 10-month-old girl. She is from actually Rawalpindi, Islamabad. Her grandfather was some army general, and they had a ability to afford to US, UK. They have been going there for many, many months, and then ultimately they were referred from France to me that you can go back and get him operated from here. And this is, can you run the video? This is when she was 11-month-old. We wanted to show that her right arm is lying at the side. There is no motion, nothing. And her mom was trying to wiggle her that if she can move her hand. You can see absolutely flail upper limb. So where I had to do explorations, I had to do some nerve transfer and nerve grafting because the C8 and T1 and C7, some of the actually nerve fibers, roots, they were still actually were intact, and we have to do nerve grafting as well as some nerve transfer combination. These are the actually per-operative pictures. I will just actually skip those. These are my own where we have to do little nerve repair. Can you run this video? So this is the kid, 2.5 years down the line. The kid sitting in the center. You can see an elevation at the shoulder. She had a pretty good elbow flexion, but her wrist extension is not there. We have planned actually surgery next month, in the month of December, for her tendon transfer to the wrist extension and the finger extension. So surgical treatment in these kids does pay some results, and we are satisfied that if you do an early exploration. Now, here comes when most of us actually deal with those kids when they have not been referred in an early stage and they come late, especially the pediatrician themselves they have been treating, or they have been undergoing physiotherapy, and now they have some residual deformity at the shoulder, elbow, wrist, and the hand, and there is a functional limitation in these people. So here we have to do some work on the muscles. So I just want to know if some resident they are sitting, what is the function of rotator cuff? I always ask to the students and even to the resident and doctors, and honestly speaking, none of them gives a satisfactory answer. Yes, it keeps the head against the glenoid cavity during all phases of elevation. It steers, guides, and glides the humeral head. When I was a student with Dr. Tahseen Chima, my dissertation topic was a Saha procedure for paralyzed shoulder in polio kids. And we have, at that time, 9 kids we operated. It was 92 November. I still remember I came in Karachi, I won the gold medal. And that's I got an entry to the AKUH. And the AKUH people, they said that we would hire you. And in the month of December, I was here because I had spent enough time, like 2 years with Dr. Tahseen, and most of the things I had learned from it. So you can see here, without rotator cuff, as the deltoid is pulling, it is pulling the humeral head in an upward direction. And as in a rotator cuff tear, you will see the head will go and bang to the underneath of acromion. Here, if the rotator cuff is intact, you can see here, there is a nice motion that the whole head actually moves up, coupled with the scapulothoracic motion. So, various tendon transfer, and Dr. Kamran is sitting with me. We did a tendon transfer. It was most probably your dissertation topic. Yes, and he, yeah, we have wrote a paper. Now, there are a lot of actually names regarding these various surgical procedure which we do, interior releases along with the tendon transfer, especially latissimus dorsi alone or latissimus dorsi along with teres major collectively. We have been doing it. So in interior releases, we do sometimes coracoidectomy, and we do lengthening of pectoralis major, subscapularis, and then do from interiorly we dissect once you have done a lengthening of a pec major lifted, so in the groove you identify biceps tendon, and underneath the biceps tendon you will have a, as we always say, lady between the two major latissimus dorsi and the teres major muscle. And they are dissected, severed at this point, and then with the posterior incision you drive them back behind the triceps and attach to the infraspinatus and the teres minor muscle. So with that, we have done a lot of actually cases. I will, can I have a video? So this is another case which I just wanted to show. Many times people, they come very, very late. And when they come late, you will see actually posteriorly dislocated humeral head. And I have operated almost 6-7 cases where I had to do a lot of works to restore actually humeral head to put it back into its position. So here you can see, this is a case that once you have done your releases, with an arm abducted, you should be able to do external rotation as well as internal rotation. I have muffled the sound myself because there was a lot of noise behind it. Okay. Next video. So this is the kid I was talking about who had actually no internal rotation and elevation was very, very limited. This girl is a niece of an orthopedic surgeon from Hyderabad. When I explained to him that we are going to do this procedure, he did not believe that nobody can do this. I said that, okay, you can go to my teacher, Dr. Tehseen Chima, and ask him. He will. Then they visited Dr. Tehseen, and Tehseen then convinced him that he is a good man, maybe he will do a better job if you are living there. But Dr. Tehseen, because we learned this technique from Tehseen, okay, I will just go. Next, dikhaiye. So this is actually peroperative picture. We are doing, sorry, this is, we are doing coracoidectomy. I will just actually go over this slide because coracoid actually impinges over the interior aspect of the margin of glenoid. I will just, next. So this is the case, you can see here the click. Here it comes back and then immediately goes back. So in an external rotation, it remains in its place. And then you can see the fascia, axillary fascia is so tight, which I'm just pointing, it needs actually just fasciectomy. You have to do it, otherwise abduction becomes difficult. The other thing is that if you see clearly with an external rotation, it comes where the moment you adduct the arm and do internal rotation, the head is actually again dislocated posteriorly. So these are the few of diagrams where you can see a functional outcome with an internal external rotation, elevation which you get and post-operatively. In one slide I have put all these few examples. There's another case, elevation only up to 70 degree, and you can see forward flexion is this much. And then this is the shoulder spica cast, which I usually immobilize it. I call it a liberty of statue position, and that remains for 5 to 6 weeks. And this is another case. Now these are actually very old pictures. Some of these, they are actually young men, and a couple of months earlier, last year, one of the women came to me. I operated her back in almost 25 years earlier, and she said that my daughter has same problem which I had. Unfortunately, she had also Erb's palsy. I operated her for an Erb's palsy. She is the one actually I operated, and so you can see the amount of elevation, internal external rotation which you get in these kids post-surgery. And this is actually criteria which we actually published, and we use it actually Mallet criteria for our functional outcome. I will not go into the detail of those modified. So tendon transfer is a good option for the late cases, but in certain cases when elevation is good and external rotation is limited, external rotation osteotomy is also a good option. And especially if you do external rotation ostomy inferior to the attachment of a deltoid muscle, it gives a pretty good result coupled with tendon transfer. So this is the one kid. Can you run this video? This should be the last. This is from Peshawar, the kid who came, we operated, and you will see that he had a pretty good motion initially, and you can see the amount of external rotation which he has. His father was quite happy. The only problem which I face with an internal rotation, there is a prominence of a scapular border, and other people will agree with me that even when these kids, they come late, so there is a systematically coordination between the scapulothoracic and the glenohumeral motion. That aspect is usually lost, and you will see some element of a lag behind that coordination. And there may be a little prominence of vertebral border of a scapula during the arm elevation and internal rotation, especially not an external rotation. When they do an internal rotation, they try to touch opposite shoulder. There is some tightening of a serratus anterior muscle also, and fascia. Thank you. I will just stop it here, and if there are any questions.
Sir Hashmi, excellent talk, and you covered each and everything regarding obstetric brachial plexus injury, and starting from the anatomy and pathology, and then the treatment at early stages and the late stages. You have done a lot of work on it. So with the passage of time, the things are getting advanced. What I want to comment from my side, and things are changing, and still people are doing a lot of work on it.
Yes.
And if we say there is a question that for obstetric brachial palsy, where we stand in Pakistan, then the answer is that we are not standing anywhere. The work you have done, or few people are done on it, and the rest, everything is going at their own. So, three things that I want to just add and comment. That initially 3 months are very important, as you told.
Yes.
And now it is proven that the subscapularis contracture gets very much matured within 3 months.
Yes.
So that's why the mother should be advised that she should work more and more during 3 months. And the duration between the 3 and 6 months, you can make your decision regarding surgery, whether you go to explore or going to do the nerve transfer, and these are the excellent work done by you in this. In late stages, now the things are going to change now. And probably the room for open surgery is getting down and down with the passage of time. And we also having the approach in the same way that the issue is with the contracture only. There is contracture of the subscapularis muscle, and there is contracture of the anterior capsule. If we release the contracture, then there is a lot of improvement in the patient itself. Particularly, it is in the studies that the 60% patients get improved. So what we are doing, I am just adding my experience, that we rarely do open surgery in late cases. We go arthroscopically, and with arthroscope, we release the anterior capsule as well as the subscapularis muscle, and from the very next day, patient starts movement and physiotherapy, and generally there is improvement within 3 to 6 months. And the next addition is that if there is no improvement within 6 months, then again arthroscopically we transfer only the LD at the place of the infraspinatus muscle, and it works very good. Then again with the transfer of the LD, we apply the sort of the splint for that for 6 weeks, and it works very well. Or the minor patient, the youngest patient, we did arthroscopically, the age is 2 years, and the higher with the 22 years. So the results are very nice, and very, very rare patients we went for open surgery. So thank you very much. It's again a great talk, and I hope that we will continue to interact with each other. Thank you, sir.
Thank you, Dr. Khalid.
Sir. Assalamu alaikum, sir.
Walaikum.
Sir, it's like a reminder for me because many of these things date back to like more than 20 years where I was part of it.
Yes.
I have a question and a comment. We know in most of these children, the function of the suprascapular nerve does not come back.
No.
Now we say, see biceps at 4 weeks, see biceps at 3 months, at 6 months. What it does, that it takes you to very late stage, like 9 months, and the decision comes late to do something. And we are way beyond the stage of nerve transfer. What do we do in late stages? We are actually doing a LD transfer for to compensate that particular suprascapular nerve.
Yes.
Many of these children have some reasonable function of deltoid. Most of them have some function of biceps, if not a lot. So actually they require that suprascapular nerve function. So my assumption is that if there is no biceps function at 3 months, we need to think about doing a very early suprascapular nerve transfer, the spinal accessory to suprascapular, because that transfer, doing that transfer late has all the problems. So what do you think about that, sir?
Kamran, you're absolutely right. But you see, to convince the parents, it is a hell of a job. In a 3-month child, although I'm working in Akhan Hospital, the infrastructure and setup is pretty good, where the 3-month child, it can be anesthetized. But once actually at 6 weeks or 3 months, biceps comes, on the one hand, if you see the opposite side of coin, there is a good chance that the child will have abduction over a period of 6 months. So this is one thinking. The other thinking is that you do, if there is no shoulder elevation or abduction, you do EMG nerve conduction at this stage, mark it, and then you repeat your EMG nerve conduction after 6-8 weeks before 6 months. And if the 2 EMG nerve conduction, they do not show up, then I will definitely try to convince the parent, now this is the time when I should explore the brachial plexus. And even if I don't explore, simple with a small incision, one can do through interior approach, spinal accessory motor branch through the suprascapular nerve. And it is much easier, it is rewarding, and I do agree that earlier you do it, better the outcome would be. Later on, contracture and the muscle fibrosis becomes worse. And as you do earlier, supraspinatus will come early. But you see, infraspinatus will have a less power. So chances of external rotation would still be actually decreased. So that's why in an older child, you see there is a good elevation, but external rotation doesn't come. Because even when the axillary nerve is being reinnervated or being regenerated, it will actually supply to the anterior and middle part, but the posterior part and the teres minor still would not be functional. And that's why external rotation is the most weak component. And second component, like Dr. Khalid Masood also said, latissimus dorsi nowadays, a single muscle is sufficient to do for an external rotation transfer. Regarding arthroscopically, I used to do a lot of arthroscopic for the wrist, and this, we had a 2.5 scope. Over the last 3 years, I'm unable to get it because one of our actually sports medicine guy, they tried to put into the ankle joint, and they broke it. So getting those scopes, especially in AKUH and stuff, it involves a lot of red tape. So although in adults we do an arthroscopic procedures, but I have not done actually arthroscopically tendon transfers. Although I have seen it with the French people, they do it very easily and quickly. So let's must dorsai. I have not been trained because I have not done any cadaveric workshop on that. Until unless I train myself on a cadavers, I will not actually do tendon transfer arthroscopically.
Sir, what I'm saying is, see, it is that you have difficulty in convincing the parents. But I think even as hand surgeons, we are probably not convinced ourselves that we need to do this transfer and do this early.
No,
we are thinking more about the biceps and the biceps and the biceps. Because, but no, as general, I'm talking about in general. So I think this is because as the child gets older and you are doing rehab, a point comes when you can even do external rotation osteotomy. And external rotation osteotomy and doing nothing else actually brings that sort of rotation.
Yes.
And the child is able to bring the hand to the mouth. So it's quite convincing. There is some abduction. The child can bring the hand to the mouth, can eat, and it's cosmetically quite appealing. So the problem is solved. So you get to do less tendon transfers in relatively older ages then.
You are absolutely right. You see, the fourth scenario which I put up, in each scenario, I talked about shoulder elevation and external rotation and biceps. When the biceps comes within 6 weeks, the chances are 99% shoulder abduction will come back. When the biceps comes at a 3 months period of time, the chances of shoulder abduction, they are 70 to 80%, not actually beyond that. And if it does not come at a 3 months period of time, then the 2 MG nerve conductions, because you need an evidence, and people who are paying it, I'm working in a private setup, so we have to convince him, and it is a pretty costly in AKUH. So that's why once the parents, they are convinced, then I do it. That's why you see a lot of cases which I have been doing it, in convincing the parents, I had to do 9 to 10 months period of time. If you do earlier between 3 to 6 months period of time, and you know Jebele, you had also personal discussion with him also, and I also met him once or twice, and he also says that 3 to 6 months is a golden period of time. Once you have passed 6 months period of time, the chances of recovery, they would be poor.
Thank you, sir.
Okay.
Thank you, Sir Parvez. And now I would like to request Professor Khalid Masood from Health Lahore to present his talk on late perilunate dislocations and multiple options on its management. Brigadier Khalid Masood.
Late perilunate dislocation is usually a challenge in our orthopedic surgical practice and in hand surgery even. Basically, चीमा साहब की ये फरमाइश थी कि जी इस पे बात ज़रूर की जाए क्योंकि I think that everyone should come across with the late perilunate dislocation in our setup. We just start with this example. A 30-year male patient who had a serious injury to the left wrist 50 days ago. He was in Malaysia and presented with painful restricted movements in their emergency, and they got this X-ray. And this is the PA view and the lateral view. The situation and story was a bit ambiguous. So they asked for CT scan. And what did they see? In CT scan that there was a perilunate dislocation. And इसका यार ये indicator किधर है? नहीं है? अच्छा इस पे चलेगा ही नहीं है। अच्छा and there was a fracture in the capitate as well. And there was a fracture in the tricutrium, and there was a fracture in the scaphoid as well. Here. So what to do? इस सारे सिनेरियो को समझने के लिए, इसको जाने के लिए, just we need a bit background. I will go that we come across up to 25% injuries. ये तो 25% वो है जो कि एक American data है. In our setup, and you all are sitting here, this is very, very high frequency in our setup. And these neglected perilunate dislocation, the cases, these are the basis cases, there is no consensus on the most appropriate treatment. कि करना क्या है और किस वक्त क्या करना है. And the alternative procedures such as proximal raw carpectomy or lunate excision or wrist orthodesis, these are described in the literature. Some have long-term good results, लेकिन कुछ के results अच्छे नहीं हैं. क्योंकि जो issues हैं with the late presentation, वो ये हैं कि there you see the extensive fibrosis and scarring that have damaged each and every anatomical structure. And there is always uncertainty of the result कि ये outcome क्या होगी ये सारे. And there is possibility of developing AVN and reduced lunate post-operatively कि जी post-operatively lunate कैसे behave करेगा हमारे साथ. And there is always potential for mid-carpal arthritis and development in the late cases. अगर literature हम देखें तो इस पे लिखा क्या है mainly? ये जो एक study है, they manage scaphoid perilunate dislocation up to 40 days. वो कहते हैं कि जी 40 days के अंदर अंदर हम अगर इनकी internal fixation कर लें तो that will be a successful outcome. फिर another study है, वो उसको उन्होंने 2 महीने तक अपना लिए लिखा है कि जी 2 महीने तक अगर कर दी जाए तो बेहतर है. Then another study said कि जी 35 weeks में अगर ये कर दी जाए तो हमें रिजल्ट अच्छे मिल जाएंगे. So, what we are doing, basically, from 2016 to 2022, we had an experience with 31 patients. The cases were classified as neglected if these were undiagnosed or untreated for 6 weeks. कि जी अगर 6 हफ्ते तक उनका अनडायग्नोज रहें या ट्रीटमेंट ना हो तो हम उनको वी कॉल इट कि ये जो है निगलेक्टेड केस है. तो अमंग ऑल पेशेंट्स 20 केसेस वर इनिशियली मैनेज्ड इन पेरिफेरल सेंटर वेयर द डायग्नोसिस वाज मिस्ड एंड 9 पेशेंट्स गॉट ट्रीटमेंट फ्रॉम लोकल बोन सेटलर्स and 2 patients remain undiagnosed due to polytrauma associated with head injuries. The average age of the patient was 38.5, starting from the 21 to 59 years. Male were 25 and there were 6 females. The dominant hand was involved in 25 patients and dominant side in 6 patients, the other side, non-dominant side in 6 patients, and 2 patients had bilateral involvement. The treatment delay was ranged from 6 weeks to 1.5 years. So we performed open reduction and internal fixation in 14 cases, up to 25 weeks or less than 25 weeks, when we said that there is no coronal damage. And PRC was done in 7 cases. And the lunate excision was performed in 3 cases, and total wrist fusion in 5 cases, and left unoperated 2 cases, because the patient said कि जी हमें कोई इतनी ज़्यादा problem है नहीं है, and we can work very well, or just for making the X-ray fine, we didn't do anything. So in our cases, the average the duration was 5 months. Under 5 months, we can perform the open reduction and internal fixation. And our findings were similar to that studies जहाँ पे भी ये था कि जी 25 weeks में ये हो सकता है. And this also became a study significant कि अगर हम इसको further delay करें, तो then we can go for another procedures. So in our experience with 14 cases, stabilization of the reduction of the corpus with the K-wire, we just used K-wire for scapholunate, lunocapitate and lunotricutal joints, कि जी उनको हम stabilize करें इसमें सारे. And we believe that with extensive fibrosis and scarring in the chronic cases and the extensive dissection that required, और उसके लिए ये ज़रूरी है कि ये जो dislocation है इसको reduce किया जाए. तो just go see कि ये हमारा wrist joint है, और these are the palmar ligaments and these are the dorsal ligaments. ये ligaments ऐसे तो मौजूद हैं, लेकिन on ground in late cases में these ligaments you can't find these ligaments. और जैसे वो आजकल मीम बड़ी बनी हुई है कि जी वो ligament तो बस बढ़ गए. और you see the gilula lines, और imaging में हम use करते हैं generally X-ray and CT scan, और PA view is more important, लेकिन इससे ज़्यादा important जो है वो lateral view. Here lateral view you can see the alignment of the radius, lunate and the capitate. Mechanism of injury is generally the outstretched hand. और Mayfield classification में what we see that there is initial scapholunate ligament की disruption है, फिर lunocapitate ligament की disruption है, फिर lunotricutal ligament की disruption है, और फिर उसके बाद lunate की dislocation है. ये 4 stages हैं. अगर हम उनको X-ray में देखें, तो this is the stage 1, and this is the stage 2, and this is the stage 3, and this is the stage 4 where you can see the lunate putting outside. So, करना क्या है? There are general principles कि जी initially पहले आपने diagnose करना है proper with X-ray and CT scan, and then if there is a fracture, then fix the fracture as well. Yeah, these are the general principles. तो surgical treatment can be performed with the reduction and the pin carpal bones, and be sure that capitate is seated on the lunate, and be sure to correct the rotation of the scaphoid and the lunate, and repair the extensor capsule, agar ye capsule available hai us waqt to, then release the carpal tunnel if required. So principles में what we have to do कि जिस scapholunate इसको fix करना है and lunotricutal इसको fix करना है and then scaphocapitate. मतलब ये कि at least these fixation should be performed. And this is the lateral view and this is the AP view. This is a case type 3 transstyloid crack, this one. And you see there is a perilunate dislocation, late case hai. And this is the fixation of the styloid, and this is the scapholunate fixation, scaphocapitate fixation, and scaphotricutal fixation. After removal of pin wire. And this is another case with transcaphoid perilunate fracture dislocation. And this is the fixation, and the fracture is fixed with the headless screw. And again, the lunotricutal and mid-carpal joint are fixed. What we do initially, additionally, मैं क्या करता हूँ कि जी मैं additional एक wire डालता हूँ through ulna to the tricutum. ये wire, I keep this wire for 4 to 6 weeks. Then I remove this wire and then start physiotherapy. इसकी उसी वक्त इसकी फिजियोथेरेपी शुरू कर देती जबकि अदर जो pins हैं, these are at place. Then remove this place after 3 months. This is another case. This is the fixation like this. So here what we need to see another additional thing, that radius, lunate and capitate, it should be in line, and the lunocapitate ligament, it should be aligned as. So the same case that we discussed initially, and this was the case जो कि हमने पहले बात की इसके ऊपर, there were so many fractures here, and it was fixed with the help of the K-wire as well. So after removal of the K-wires and after the removal of the wire, nice movement. Another case, type 2 dislocation with lunate and radius fracture. A 32-year male, outstretched injury and painful wrist. It was neglected 7 weeks. And what we had this side, there was a fracture of the lunate. It was probably the avulsion fracture of the scapholunate ligament. And there was a bit die punch fracture at the lunate fossa as well. And when we see, there is a bit dislocation in it. So on CT scan, you can see the die punch here, and there is fracture of the lunate as well. So there is CT scan, and you see this. So it was the scapholunate was fixed with the K-wire, and the lunate was fixed with the headless screw. And there was a fiber wire was passed through the screw, and there was additional repair and reconstruction was done between the lunate and the scaphoid with the help of anchor suture. And the die punch, it was corrected with the help of this volar plate. Then another case was the transcaphoid type 3. And sorry, the x-rays are not too clear. These are the CT scan, and it is fixed in the same way. The scaphoid was fixed, and rest within the same principle. These are the close view of the X-ray. Then the lateral injury, transcaphoid dislocation, 41 years, 6 weeks. And it is fixation. And transcaphoid type 3 injury, you see. And its fixation of the scaphoid within the same principle, keeping in view. Then the lunate excision. Rest everything is at its place, but lunate is very prominent. It is outside like this, everything, and one of the goat is very, very prominent. So in late cases, if the patient is not very much heavy work, so the lunate excision can be done successfully. But what additionally I have started to do, that I do fusion of the scaphoid with the capitate in such cases. That works very well. So there is another case, the type 3 fracture, lateral view, and it was managed somewhere else. And you see, and when the wire was removed, there is a lot of panarthritis here. And the situation is like these. So such cases, these are basically the candidate of wrist fusion. When you come to you with, then the wrist fusion should be performed. So post-operative care, we remove the pen and begin the range of the movement and strengthening generally at full use by 3 months, and generally functional range of movement we get is the 4 to 6 months, 40 to 60 degree, and monitor for avascular lunate collapse. So what is my management strategy? My management strategy that up to 25 weeks, fixation can be performed. If the duration is more than 25 weeks and less than 25 weeks, but the situation is irreducible and cartilage at proximal pole of the capitate then is damaged, then go for PRC. And in type 4 injury, if it is reducible and there is damage at the chondral level, then go for the excision. And regardless of the duration, if there is a panarthritis, then go for the fusion. Then the duration up to a year with minimum symptoms, then you can leave the patient as such. So the conclusion, perilunate dislocation with late presentations are always a challenge to manage with. Despite late presentation, patients with chronic perilunate injuries can be treated with open reduction and internal fixation with satisfactory results. And we observed favorable functional results of ORIF in neglected cases with perilunate dislocation up to 5 months after injury. And patients with irreducible dislocation or major articular damage may require wrist salvage procedures. And the development of the AVN or mid-carpal arthritis was not a major disabling factor as long as stability of the wrist is restored. ये एक बड़ी observing sort of finding थी हमारी. So beyond 5 months, the alternative surgical procedures like PRC, lunate excision and orthodesis on the basis of the reducibility and AVN of the lunate and chronic damage of the cartilage and arthritic changes. So these, इनकी basis पे फिर हम salvage procedure की तरफ जाएंगे. Thank you very much. I would love to have any question regarding this.
Sir, thank you so much. In the interest of time, I think we'll let people have direct chat with you rather than have questions.
Sure.
Because
Thank
we
you.
have a lot of session remaining, and so I really liked your talk. And it is, you see these wires that you are talking about, if you just have these 3 wires in position, most of the things are done, most of the cases. You are perfectly right.
Thank you, sir. Thank you very much.
My request to all presenters is that only take 3 minutes now, from now onwards, for your papers. So I would like to request Colonel Khalid Qureshi from HULS to present his paper on arthroscopic management of TFCC, his experience at HULS. Thank you.
Assalamu alaikum, Bismillah ar-Rahman ar-Rahim. Okay, I've been given only 3 minutes to discuss about the arthroscopic TFCC repair experience at HULS, which is quite difficult for me to cover up in 3 minutes, but I'll just try to rush up if I can have my presentation.
Sir, आप 5 से 7 मिनट ले सकते हैं, sir.
Time limit is for civilians. So the TFCC has remained a problematic area for hand surgeons as well as orthopedics as well as the plastic surgeons who call themselves hand surgeons. And a very senior professor this evening told me a very funny kind of explanation of the TFCC, which I cannot obviously describe here. But yes, TFCC is a difficult area to really understand, and it's very difficult to really justify its arthroscopic management. But I'll just quickly rush what we do or what is our rationale at HULS. So the history, I'm not going to go into the details which you already know. The triangular fibrocartilaginous complex is the ulnar-most component of the radiocarpal joint, and its injury causes ulnar-sided wrist pain as well as DRUJ instability. So if we just look at the triangular fibrocartilaginous complex from the bottom, it is actually the extension of the radial cartilaginous surface onto the ulnar head over the styloid, just to make a flat radiocarpal surface. And this TFCC is actually comprised of 5 major components: dorsal and volar radio-ulnar ligament, the triangular disc itself, the sheath of the extensor carpi ulnaris, as well as the ulnocarpal ligaments. So these 5 components are required to be addressed whenever we have to manage the TFCC. And there are certain, okay, I'm not going to go into the detail of these factors. If we just look at another pictorial representation, so this is just the cartilage which we used to study in anatomy in our first year, second year classes. But now for us, it is this huge complex comprising of the ulnar collateral ligament and the sheath and the ulno triquetral and the ulnolunate ligaments, as well as this triangular cartilage has two attachments at the fovea. So I'm not going to go into the detail. This is another like anatomical representation of the same thing, which we all know, or we don't want to know, that's something else. But at least we have seen this picture once just to understand what the hell is TFCC. So the important thing is the physical examination. The pain and clicking, the clicking actually represents the instability in the DRUJ. Basically the ulnar-sided wrist pain and the DRUJ instability are the two major factors which actually guide us through the thought process of its management. Plain radiography actually has no role except in certain cases where we are suspecting TFCC injury in connection with the distal radial fractures as well as the ulnar styloid fractures. In most of the cases, we ignore the ulnar styloid fractures, which are actually harboring a TFCC injury. Wrist arthrography is, I think, obsolete. We haven't done that, and I think it's not being done anywhere because it's not going to give us any yield. MRI remains the mainstay because the magnetic resonant images are really, they really show us the actual breach, and that's true in the T2 weighted and the fat depleted images, that we can see the tear, and we can even classify the tears as well. So the MRI remains the gold standard. So amongst the clinical features, I think the ulnar-sided wrist pain with or without DRUJ instability, and the diagnostic thing is the MRI, and the famous Palmer's classification in which the type 1 represents the traumatic injury and the type 2 represents the degenerative injuries. And another representation of the type 1 injuries according to their sites in the TFCC. Now, the important thing is that all those TFCC injuries which are causing pain, but there is no DRUJ instability, is supposed to be treated non-operatively to begin with. So if you come across any TFCC injury diagnosed through MRI, don't rush up to repair it, especially if there is no DRUJ instability. So that's what we do, that in symptomatic traumatic cases, we go for a 3 months trial of a conservative management. But for that, we need the immobilization and anti-inflammatories, but the mainstay remains that the symptoms are there without DRUJ instability. When the DRUJ instability is there, then there is no point in going for a non-operative treatment. Then we have to opt for an operative treatment. Whether open or arthroscopic, that's your choice. But with DRUJ instability, I think non-operative management should not be pursued at all. So that's another thing which is actually showing the same thing, that in traumatic tears with neutral ulnar variance, and the same thing if there is wrist pain and neutral ulnar variance without any DRUJ instability, we can go for a trial of non-operative management of the TFCC injuries. So what we have encountered about 98 patients, and out of those 98, only 23%, like 23 cases, went for the arthroscopic repair. So the two-third of the cases were managed by conservative means. During the arthroscopy, it's definitely the minimal invasive repair of the TFCC is the gold standard. The more you're going to give the incision, the more will be the scarring, the more will be the fibrosis, the more will be the stiffness. So that's why everyone is going for the minimal invasive repairs. So we only do arthroscopic repairs. Very occasionally, in which we come across through arthroscopic diagnosis that the TFCC is not the problematic, the triangular cartilage is not the problematic area of the instability, then we have opened the cases. Otherwise, almost all of the cases have been repaired arthroscopically. So we have edge that once we put the scope in, we can see the size of the tear, we can always see the unstable flaps, we can see the chondral damage and the synovitis which is occurring alongside with the TFCC. We can really go for a trampoline effect. That's a very hallmark for the patency of the triangular disc itself. And the very important thing is that distal radial fractures, we often forget about the distal radius fractures, that if it is not meticulously reconstructed, the articular surface is not meticulously reconstructed, especially when they are associated with ulnar styloid fractures as well, they are likely to end up in a TFCC problem. So there have been so many things in that according to the classification, but I think I should just go through this. Okay, arthroscopin versus open repair. So there have always been a discussion in our forums that whether we should fix the distal radius with the internal fixation or should we fix it with the K-wires, or some people are presenting data that we are very good with the external fixators. So there have always been a debate that which technique is good. So fortunately or unfortunately, people have been working on that. And in certain cases, it has come across that in athletes, or rather in us as well, the arthroscopic repair gives us an early return to sports or our work. That's the only difference. Otherwise, the open repairs are as good as arthroscopic repair, but more dissection, more scarring, more stiffness, more time to go back to work. So post-operative, obviously, after arthroscopic repair, we have to immobilize the wrist in a certain way for a certain amount of time. Complications are always there with any surgery, even with the circumcision we have these complications, so why not with the arthroscopic repair? So there can be infection, stiffness, and repair failure, and pain might continue despite your best of the repair. Strength might decrease in certain cases. And these are some pics which we have been taking from our patients. The Chinese strap for the traction in the wrist. Certain cases cannot really describe everything in detail right now because of the constraints of time. This is the checking of the trampoline effect with the help of a probe. This was actually a video which we have don't time to run. This actually shows what is the trampoline and what happens, how it looks like when it is lost. That's a debridement of a degenerative injury. Most of the degenerative injuries don't require repairs, they just require debridement. And most of the traumatic injuries, only they require the repair. And that was also a video showing how we performed the debridement, and under this burr, we could see a defect, central defect, a central degenerative defect to be exactly. Oh, luckily it's running on its own. I've done nothing. So that's how, this is the defect, this is the central degenerative defect, which is just being debrided. The ulnar variance is quite neutral. A positive ulnar juts out through this defect. Then this is the repair. Sometimes for the repair, we have to anchor the TFCC to the fovea and to the ECU sheath. So for that, we might have to give a small neck to just anchor it there, fix it there. That was another video showing the same thing. Okay, that's a video showing a lost trampoline effect. So the trampoline is as if you are just beating on a drum. But if you just look at this video, it seems as if it's just a bed of feathers where you're just spreading your probe. So that's a kind of representation of how we can see the lost trampoline effect. So this is synovitis, and pass the needle across the ECU. We're going to pass the threads across this, going to hold it, pull it back. Eventually, we're going to just thread it to the ECU sheet the way we have just shown. This is our team after the end of the work, bit relaxed and bit contented after a very nice repair. I've been rushing through, I don't know how much I could really justify with the arthroscopic repair, but just to summarize things, TFCC injury needs to be recognized in degenerative as well as acute settings. It can be associated with distal radial fracture, which we come across very commonly. And in those distal radial fracture, if the articular surface is not maintained appropriately, and if the ulnar styloid is forgotten to be fixed, usually they end up in the TFCC symptoms. TFCC symptoms associated with a stable DRUJ, supposed to be managed conservatively to begin with, and only those cases should go for immediate arthroscopic repair in which the DRUJ instability is present. Open arthroscopic, both have same results in 10 years' time, but for the return to the normal work, arthroscopic repair is the best. I think I could just do this much of the justification with the TFCC in 3 to 5 minutes. I hope if I can take some questions, maybe I can answer them if I'm allowed to.
If there are burning questions, they are most welcome. I think it was a great presentation. At least it gives an insight into how you can approach the TFCC arthroscopically, the trampoline effect, and how you can debride it. And then I think it's very important to understand that you may need a small nick for the repair because you have to anchor a suture. So I think the anatomy and what you have shown, it's like a learning curve. It's not so easy.
Sir, it's difficult to really grab the actual crux and actual essence of the TFCC. We are still learning and we are still struggling. But that was just our experience.
Yeah, it's a great experience. It's a great experience. Thank you. Thank you so much.
Thank you.
Thank you, sir. Bismillahirrahmanirrahim. I am Dr. Talha Khalil. I want to share my experience of mini fragment, low profile plating at a peripheral health center. I do work at Tehsil Headquarter Hospital at Dera Adi Khan district. This is my hospital where I do work. So I won't go into the details of the epidemiology due to a lack of time. So the types of fracture of metacarpals are oblique, short oblique, transverse, comminuted, metaphyseal, and displaced, and extra-articular or intra-articular fractures. So it is a very debatable, acceptable criteria because it is only radiographic criteria, while in hand we prefer to have a functional outcome. But conventionally in the books it is written that 20-degree angulation is acceptable in index and long finger, 30-degree in the middle finger, and 40-degree in the little finger. While the angulation is acceptable 50 to 60-degree in little finger, especially in the Boxer's fracture. So regarding some biomechanics, these are very less stable if present in the index or little finger metacarpals, as these injuries lack the inherent soft tissue support and stabilization. While the transverse and oblique fractures, they tend to result in a dorsal angulation deformity. So a quite long series of radiographs. So very important slide. What are the key factors in decision making for fixation of the metacarpals? First, it is open or closed fractures, then number of digits or metacarpals involved, the stability of the specific fragment, and the degree of comminution and displacement, and especially the rotational malalignment, which is a very prime factor for the indication of surgery, the dominance of the hand, while occupation and the current working status of the patient. And very important is the athletic participation. Some patients, they opt for surgery. So it is a way how to assess the rotational deformity. When you ask the patient to flex the fingers, you see that all the fingers normally they must point towards the scaphoid tubercle, while in this case it is not so, and the finger may have a rotational deformity. So it is a very strong indication of fixation of the metacarpals. So Boxer's fracture is a very common of the metacarpal neck fracture, which is the weakest point of the metacarpals. This is the way how you reduce the metacarpal by flexing the MP joint and using the DIP joint curling back on its own self. So use this maneuver to reduce the metacarpal fracture. So what is the rationale of the management behind all the hand fracture? Is the restoration of anatomy and function. So it is a very important publication in American Journal of Plastic and Reconstructive Surgery in 2021. It says that the X-rays do not demonstrate the function, and therefore it only acts as an adjunct to the care of the patient. The main goal of treating hand fractures is to restore the function. Another study from Korea in 2020 reveals that mini plates are not just small metal plates, and they help to maintain the reduction of the large fragments and they increase the fixation force for non-union. So nowadays it is an increasing trend towards the fixation of the metacarpals so as to achieve the hand function. So regarding preparations, you have to select the implant, 2 millimeter locking plate set. This is locking mode. Multiple configurations of the plate like Y, condylar and strut. And you have to go for you have some very fine instrument sets in your OT. So 2 millimeter locking plate, and you have to drill with the 1.5 mm drill bit with quick coupling. So I won't go into the details of the hardware. So this is a dorsal approach which is preferable to avoid the neurovascular. Some people, they also use the dorso-ulnar approach in the little finger.
Excuse me.
Yes, sir.
Just hold on. May I ask the honorable members to please take the seat and let the speaker complete his talk. There is enough space on the right side of the hall. Please sit down. Please sit down and be quiet. Let the session happen. May I ask the honorable members to take seats, please? There is enough space in the hall. Continue, sir.
Thank you, sir. So in the dorsal approach, you have to take care of the cutaneous nerves and veins. And also you have to retract the extensor tendons. And as there are tendinous junctions, you may have to divide, but you must remember back to repair it after the surgery. So avoid muscle detachment, and very important thing is that don't put the Homan retractor around the metacarpals, because you can see their tip may damage the volar structures. So try to use the Langenbach retractors. So temporary fixation with the K-wire. You may bend the plate prior to the fixation so as to achieve the proper contouring. Just don't drill eccentrically. This is a very important catch point because you don't have a second chance to reinsert the screw. So you must drill within the middle of the metacarpal belly. This is the way how you achieve the compression. So some people, they advocate to close the periosteum also over the hardware. So proper wound closure is the layered closure, not only to the skin. This is the functional position, how you mobilize the hand with the MP joint in flexion, wrist in extension, and full PIP flexion. This is a way of elevation, and after that you will advise the patient to do the 6-pack exercises. So let's have a quick look at some cases which we performed at a government hospital at Tehsil headquarters. Boxer's fracture, dominant hand, young patient. So we applied this low profile 2 millimeter locking plate by the dorsal approach. Immediately post-op X-ray. At 3 to 4 months, he is having good union. He is having good cascade of metacarpals. Nothing is depressed. Good wound healing. Active extension, good intrinsic hand function by having good abduction of the fingers. He is able to join his office very quickly after the surgery. Please play the video. So this is the rationale of the management behind all the hand fractures to achieve the flexion of the fingers very early. Next case, metacarpal neck fracture. The low profile Y-shaped locking plate applied immediately post-op. He is a male of 55 years, but he is a laborer. He loves to do the manual work. So we use a dorso-ulnar approach in this case. You see the functionality of this patient. He is a doctor. He is having the severe trauma. He is having the fracture of the distal radius, disruption of the DRUJ with the fracture of the metacarpals 3rd, 4th, and 5th. So it was a challenging case, wrist dislocation. So what we did, we pinned the DRUJ, we pinned the radioscaphoid, we did the percutaneous pinning of the 5th metacarpal head, and we applied the low profile locking plate in the 3rd metacarpal. So at 1.5 years old follow-up, the wires are removed, the bones were healed, and he is having quite stiffness of the MP joint of the little finger because the fracture was intra-articular. Please play the video. Video, please.
Dr. Saab, we have 1 minute to conclude.
Yes, sir. Just video, please. Short video. He is doing his rotational activity. Next case. Both metacarpals were plated by single approach. Video, please. So a couple of cases. Comminuted fracture with a butterfly segment. It was quite unstable with rotational deformity. Video, please. So this is the case of the boxal fracture. So sometimes you have all the plate in your inventory. You can see a couple of cases here in which the bones are fixed. So three metacarpal fracture, all were in rotational deformity, all were fixed in a young patient. Thank you so much. So now I would like to request Dr. Faraz Ahmed from Guru Ki Trust Teaching Hospital to share his experience of treatment with steroid injection in De Quervain's tenosynovitis. Thank you.
Excuse me, sir.
Dr. Saab, please restrict the talk to 3 minutes. Thank you.
Bismillahirrahmanirrahim. Respected seniors, colleagues, and my dear teachers, Assalamu alaikum. I'm Dr. Faraz Ahmed Khan, PGR, working as a PGR at Guru Ki Trust Teaching Hospital, Lahore. Today I'm here to present my paper, which is about De Quervain tenosynovitis, a comparative study, comparison between the treatment which is done by steroids and conservative management. This photo has captured the orthopedics and spine department at Guru Ki Trust Teaching Hospital, which is functioning under the esteemed guidance of His Excellency Sir Professor Dr. Amir Aziz. It's the most common condition in women between 30 and 50 years of age. This is basically a stenosis of extensor pollicis brevis and abductor pollicis longus tendons within the first compartment. Due to excessive gripping and movements at the wrist joint, and those professionals who has high demand activity is the wrist joint, can lead to the inflammation of the tendons and tendon sheath of the first dorsal compartment, which can lead to the stenosis of the compartment and restrict the motions and leads to pain in the patients. Now you can see the 6 dorsal compartments. This De Quervain tenosynovitis is about the compartment 1. The contents of compartment 1 is extensor pollicis longus and abductor pollicis longus. Now what are the risk factors? So female gender, pregnancy, and age over 40 years. The diagnosis of De Quervain tenosynovitis is almost clinical. So these patients presented with pain at the wrist near the stylite process And on examination, there is tenderness over the styloid process near the first dorsal compartment, and Finkelstein test is positive. This diagram shows how to perform the Finkelstein test. Now management is surgical and non-surgical. And non-surgical is further divided into conservative and corticosteroid injection. Okay, so in conservative managements, we use the 4 ohm splints and take 4 weeks rest and modification of life modifications. While in corticosteroid groups, we injected 1 ml of lignocaine and 1 ml of corticosteroids in the first dorsal compartment between sheath and tendons. Now, the objective of this study was to compare the quick disability of the arm, shoulder, and hand quick DASH scores and the frequency of Finkelstein, positive Finkelstein test in conservative group and in the corticosteroid group. So our randomized control study of 100 patients, which has been done at Gurki Trust Teaching Hospital in a duration of 1 year on the basis of outpatient department. We divided the 2 groups into group A and group B. The group A was a corticosteroid group, while the group B was a conservative group, which was thumb splint base. So our inclusion criteria was the patients which falls between the age 18 to 60 years, and we excluded those patients of acute trauma or any other tumors, etc. So patients, we provide the management, whether it was conservative or the steroid group, and then we follow the patients at 4 weeks. So in our study, more than half of the patients were male, which were 64%, and 36% were female. Again, in conservative group, again, the more than half of the patients were male, while 45% were female. Okay. So in corticosteroid groups, after 4 weeks, the Finkelstein tests were positive in 11%, while it was 25% in the conservative group. While in the, okay. Now it says. So before treatment, the Finkelstein test was positive in all the patients because the diagnosis was on the basis of Finkelstein tests. And there was no significant difference between the groups of quick DASH score. So after treatment, the quick DASH score was 14.5 with standard deviation of 9.5 of patients who were conservatively managed. While it was in corticosteroid, it was 8.9 with standard deviation of 7.6. So the higher the quick DASH score, the more was the severity of the conditions. So if the quick DASH score is lower, it shows significant improvement in, as far as the functional and pain relief. The Finkelstein test was positive in 25% of the conservative group, while it was 11% in the corticosteroid group. Okay. So this is the post-treatment quick DASH score. In group B, which was conservative, it was 14.5 with a standard deviation of 9.5, while in group A, which was corticosteroid group, the quick DASH score was 8.9 with 7.6 standard deviation. So this recent study has been published by Rajesh Kumar, comparison of efficacy of injectable steroids versus conservative managed vertical vein stenosynovitis. It shows that post-intervention, 13 patients in corticosteroid groups has positive Finkelstein test, while in 29 patients, it was positive in conservative group. So as far as the literature on the basis of our study, we recommend that steroid injection produce better results in terms of relief of functional outcome and negative Finkelstein test as compared to the conservative treatment. So we should recommend this management to treat the decurrent stenosynovitis. Thank you so much. Any question? Any question? Thank you. Thank you, sir.
Thank you, Dr. Faraz. Now, is Dr. Zain Nasir here? He has to present a talk. Dr. Bilal Hussain, is he here to present his talk? Dr. Zagam Maqsood, is he present here? for his talk, Dr. Asim Islam, Dr. Shujauddin. So that's all from this hand and upper limb session of this Pak Orthocon. Thank you so much. It is a wonderful session, and we are very grateful to Professor Pervez Hashmi, Professor Tehseen Cheema, Professor Khalid Masood, Khalid Qureshi Sahab for their excellent talks. And now I would like to request Dr. Syed Kamran Sahab to come on the stage and to present the sheets. He is the former president of Hand Society of Pakistan. So, आप परवेज़ हाशमी साहब को दे दें।
हारून साहब को बुला लेंगे।
हारून साहब को?
ये तहसीन साहब के लिए। अच्छा, उनकी ले लेंगे।
I would like to request Professor Pervez Hashmi to come on the stage and take his shield from Professor Kamran. Shield, Pervez Hashmi. Pervez Hashmi. ठहरे मैं आप बैठे रहे। I would like to request Professor Harun Rashid to collect the shield on behalf of Professor Tehseen Cheema. Professor Khalid Masood from Health to collect his shield. Sir Khalid sir. Sir, come on. Brigadier Khalid Qureshi. Please, sir, come on stage. I would like to request Professor Pervez Hashmi Saab to come on stage and present the shield to Professor Kamran Ahmed Saab. Sir, Dr. Faraz, thank you, sir. Thank you. Dr. Faraz.
It is such a nice sight to see so many colleagues in the hand session. Thank you so much.
The certificate. Dr. Talha. Thank you so much. That's the end of the session. Thank you all.
तलावत वाले किधर हैं तलावत वाले?
पीर साहब, डॉक्टर पीर अब्दुल लतीफ
किधर हैं? कहाँ है उनको?
मैं क्या देता हूँ?
शोएब साहब आगे?
हाँ शोएब साहब
किधर है?
खड़े बाहर ही हैं, बुला
सबको बुलाओ ना, पहले अंदर बुलाओ ना, अंदर बुलाओ।
रेसिटेशन ठीक है?
नहीं रेसिटेशन इनसे
डॉक्टर पीर अब्दुल लतीफ साहब
इनसे करवा लें।
हाँ थोड़े से रिलीजियस टाइप है, अच्छा इंप्रेशन है।
पहले उनको बता दो ना।
मैं बता रहा हूँ।
बिस्मिल्लाहिर्रहमानिर्रहीम। Welcome you all to the 36th General Body Meeting. First of all, I request Professor Tehseen Javed, Professor Tehseen Sahab, President POA to plus come onto the stage. I request executive board members to please come onto the front seat. Executive board. Now we formally start, and we start with the few verses of the Holy Quran. And for this, I request P. Dr. Abdul Latif Qureshi Sahab to please come onto the stage and have few verses from the Holy Quran.
اللهم صل على سيدنا مولانا محمد وعلى آل محمد كما صليت على إبراهيم وعلى آل إبراهيم إنك حميد مجيد اللهم بارك على محمد وعلى آل محمد كما باركت على إبراهيم وعلى آل إبراهيم إنك حميد مجيد أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم عسى الله أن